Hello to all the students. Hello to all of you. First of all, best wishes from my side for your exam, for your all the exams, whatever exams you are going to give in this 2 months. You will be giving all the subject wise tests, you will be giving the mock test, and then final day, your main exam, that is on the 4th December. So best wishes to all of you. And now this is the time in which you have to put your persistent efforts. Remember this thing, I'm using this word persistent efforts. What does it mean? That whatever you are doing, whatever revisions you are doing, it should be continuous. Don't stop at a point. In these 2 months, you may face a lot of ups and downs, but accept the situation. This happens with each and every student. You may be lacking behind in some subject, or you may be feeling that I'm not able to memorize these things. You may have some thoughts which can be the thoughts of doubt, but keep all those thoughts away and be positive and be persistent, be continuous in your studies. Make a timetable according to the subject wise test. You have to prepare in that way. Whatever subject wise tests are going on, make sure that you prepare those subjects well in that time, right? And then the third, like this is basically like your second or third revision, you can say. If I say like second revision, then the third revision will be just before the exam. The 10-15 days you have just before the exam, in that you will have to quickly revise the all subjects. And one most important thing is that please don't leave any subject. If you feel that you're not able to revise any subject properly, then please watch the this revision videos or any other videos, like we are having the 25 important question videos which were last year, and this year also we will be having some videos for you. So do watch those videos for those subjects, like if you feel you're not confident or if you feel you're not able to revise properly. Okay, so don't leave any subject and prioritize your subjects. Whatever subjects you are strong in, please do those subjects first. And you know that whatever subjects are having a maximum amount of questions expected in the paper, please do those papers, please do those subjects. So prioritize, make a list of 10 subjects in which you feel that a lot of questions have been asked, or like a lot of questions will be asked, or in which you are confident. So those 10 subjects you should be thorough. You should be thorough with that, and that should be your strength, right? So now starting with the revision of anatomy. Now we will be revising from the workbook, and we will be going page wise, right? We will be going as whatever the topics and the regions are there in the workbook, we will be going in that way only. So starting from first, that is the upper limb revision. So what you will do, you will all will open up your workbooks, and along with me you can just revise. And as more number of times you will see the images and whatever points we are mentioning over here, this will be very, very helpful for you. It will be very, very, very helpful to you, right? So now starting with this revision over here, now we will be having a quick revision. And over here I point out one more thing, is that the mnemonics which we have mentioned earlier, those mnemonics, you should be thorough with those mnemonics, so that the mnemonics, that is the utility of the mnemonics. If you don't know the mnemonic, you have written in the workbook but you don't know the mnemonic, then it is of no use. You should know the mnemonic, and you should know that it is, that mnemonic is for which topic. Like for example, we know sulfopams, it is for the external carotid artery. We know vitamin CD, it is for the subclavian artery. So you should be knowing that. Then only that mnemonic will be helpful to you. And you know that if you remember the mnemonics, it can save you from a lot of questions. It can help you out in a lot of things. So now as we start with the upper limb, a very, very important thing is that when we talk about the clavicle, what is the most common site of the fracture? We very well know it is the junction of the medial 2/3 and the lateral 1/3, right? And this question has been asked previously. And clavicle, it is the first bone to begin ossifying. These 2 points are very, very important for the clavicle. Now as you come to the scapula, the image is very, very important. You should be able to identify all these landmarks over here. You should be able to identify this coracoid process, acromion process. Acromion process is a projection which is on the lateral side. Okay, we had used a lot of tricks to remember the various things, and we said that between the two processes, the acromion process is on the lateral side, and the other one, whichever is on the inner side, is the coracoid process, right? Then this is the superior angle, this is the inferior angle, and when you talk about the vertebral levels, the superior angle T2 and the inferior angle T7, spinous process, which is the first best answer. And apart from this, if it is not given, then you can go for T8. Then towards the posterior aspect, we said this is the spine of scapula. And when you talk about the spinal scapula, what is the vertebral level? It is the T3. So when you see this image, you should be able to identify anterior and the posterior views along with these landmarks. So this image is very, very important for you. Now over here, along with the theoretical material, along with the theory points, we will be discussing all the images also, and as well as the clinical aspects. Now coming to the humerus. Now in the humerus, you very well know that this image is very, very important, and you should be able to identify all the landmarks over here. When you talk about the upper end, very important is surgical neck. You should be able to tell that this is a location of surgical neck. And then when you talk about this tubercle which is present over here, greater tubercle, and this smaller one is lesser tubercle. In between that, you are having intertubercular sulcus, also known as bicipital groove, right? Now coming to the shaft, which is the landmark in the shaft? Spiral groove, which is present at the shaft. And when you come towards the lower end, you are having this medial epicondyle and the lateral epicondyle. The round structure, cap, it is a capitulum, and the other one is the trochlea. Now very important aspect over here, the relations of the bony structures over here. Surgical neck related to axillary nerve and the posterior circumflex humeral vessels, right? And when you talk about the spiral groove, related with the radial nerve and profunda brachii vessels. So surgical neck to the axillary nerve and the spiral groove to the radial nerve. So that is why we say if surgical neck fracture is there for humerus, axillary nerve involved, and if there is any dislocation of the shoulder joint, again the axillary nerve involved. Now coming to this fracture of the shaft of the humerus, for this we say that the radial nerve is involved. Now behind the medial epicondyle, the word over here is behind. It is behind the medial epicondyle. Which nerve is there? It is the ulnar nerve. Bicipital groove, what are the three muscles attached? The lady between two majors. So two majors are there, pectoralis major, teres major, latissimus dorsi. And pectoralis major to the lateral lip, teres major to the medial lip, and the latissimus dorsi to the floor. So this is for the bicipital groove. When you are talking about the attachments, you have to memorize for greater tubercle, lesser tubercle, intertubercular sulcus. These 3 points. The greater tubercle, lesser tubercle, for that we use this mnemonic SITS, in which we are having supraspinatus, infraspinatus, teres minor, and the subscapularis. All the 4 muscles, they form the rotator cuff. SIT attached to the greater tubercle, and the last S is attached to the lesser tubercle, that is the subscapularis. Now as you come to the radius ulna, first of all you should be able to identify between this radius and ulna that which is the radius and which is the ulna. Wherever you see upward projection, that is the ulna. And what is this upward projection? This upward projection over here, hook-like projection, is the olecranon process. And when you talk about the radius, what is the projection present over here? Radial tuberosity. Now what muscle can be attached to these landmarks? This is a question which can be asked. So we know the radial tuberosity attachment is biceps, and olecranon process, it is the triceps. So olecranon process present over here. So the muscle coming from here, triceps. If the triceps is coming on olecranon process, the biceps goes to the other bone, that it is going to the radial tuberosity, right? Now when you come to the hand over here, you should be able to identify all the carpal bones over here. When you talk about the proximal row, this is the proximal row from lateral to the medial, scaphoid, lunate, triquetral, and this small bone is pisiform. And in the distal row, trapezium, trapezoid, capitate, and the hamate. You should be able to identify it. And we have already discussed that the lateral side is always the thumb. And if you see the thumb over here, 2 phalanges, and the rest of the fingers, 3 phalanges. As well as when you see towards the upper side, this broader portion is of the radius and the other one is ulna. And when you talk about the wrist joint, which bone does not participate in the wrist joint? That is the ulna. Very correct. That is the ulna. Now when we are talking about the important points about the carpal bones, we know that The largest and smallest, we said capital of the state, so capitate pisiform. Similar for the first and the last bone to ossify, capitate pisiform. Very, very important, very, very important. Which bone most commonly fractured over here? It is a scaphoid. It leads to the tenderness at anatomical snuff box, and it is also related to avascular necrosis. For the fracture, it is a scaphoid, but when we talk about the dislocation, it is a lunate, right? And when the lunate dislocation is there, it will lead to the median nerve compression. Then hook is present in the hamate, and pisiform, it is a sesamoid bone. Now coming to the brachial plexus, very, very important over here, and we say that we should be knowing the order of the components over here, the root, trunk, division, cords, and the branches. And for that, we are having this mnemonic: Ramu Taylor drinks cold beer. This is for the components and the order of the components. Then we say that the root and the trunk in the neck, the division, it is behind the clavicle, and what is present in the axilla? What is present in the axilla is the cords and the branches. And when you see this image, you can identify all these landmarks over here: root, trunk, then we say division, cord, and branches. And very important over here, this muscle is the pectoralis minor muscle. You should be able to identify this image, and in this image, this muscle. Then as we come to the formation, we very well know formation of the brachial plexus by ventral rami of C5 to T1. Okay, C5 to T1. So we know C5 to T1 is dedicated for the brachial plexus. Now coming to the roots. Now whenever you are talking about the roots, you should be, or whenever you are talking about the branches, you should be aware of all the mnemonics. Mnemonics are DSLR, SST, LML, M4U, and star. So DSLR, last alphabet is R, so it is for the roots. DS, dorsal scapular, L, long thoracic. What is the root value of dorsal scapular? It is C5. L, long thoracic, 5, 6, 7. C5, C6, C7. Right. So first of all, we will remember the mnemonic and the root value. This is for roots, and for the SST, we say SST, last alphabet T, so it is for the trunk. Suprascapular and the nerve to subclavius, what is the root value? C5, C6. Both the nerves having the root value C5, C6. Then LML, C5, C6, C7. L, it is starting from the L, so we say it is for the lateral cord. Right. So all the branches over here, they are having the root value C5, C6, C7, in which we also include this musculocutaneous nerve. Then coming to the M4U, this is for the medial cord. Sorry, this is for the medial cord. All the M, they are having the root value C8, T1, and U, that is the ulnar nerve, it is having the root value C7, C8, T1. Now, as you talk about the median nerve, it has all the root values. And coming to the posterior cord, star. When you are talking about the posterior cord, star, for this we say radial nerve is having all the root values, and these two nerves, they are having C5, C6. That is, S is the subscapular, A is the axillary. Both are having C5 and C6. Thoracodorsal in between, it is having C6, C7, and C8. Right. So we say that R is having all the root values, that is the radial nerve is having all, then subscapular and the axillary C5, C6. And when you talk about the thoracodorsal, it is C6, C7, C8. So we have remembered with the help of mnemonic, and we have said DSLR, SST, then we said LML, M4U, and star. Now coming to these branches over here, we have discussed about the trunk. Then for the lateral cord, LML is lateral pectoral nerve, musculocutaneous nerve, lateral root of median nerve. And in the musculocutaneous nerve, now we are having an important structure, BBC. What is BBC? BBC is biceps brachialis, coracobrachialis. These are the three muscles which are being supplied by musculocutaneous, and BBC is over here, all the muscles on the anterior side of the arm. Then we have already mentioned about this, and now coming to the posterior cord, we have already mentioned about this, and over here we say for the axillary nerve, it supplies two muscles. What are the two muscles? Very, very important, deltoid and teres minor. Okay, the axillary nerve, its nerve supply is very, very important. It is supplying deltoid and teres minor. So when we talk about the radial nerve, median nerve, ulnar nerve, the radial nerve and the median nerve has all root values, and for the ulnar nerve it is C7, C8, T1, right? So over here, what branches are coming from the each portion, what are their root values, and for some of them the muscle supplied are very, very important. Now over here for the muscle supplied, I come back to this point also. The dorsal scapular, its muscle supplied is very important. It supplies the rhomboides major, rhomboides minor, and the levator scapulae, all the three muscles which are present over here on the posterior side. So that is why dorsal scapular nerve. And for the long thoracic nerve, the muscle which is supplied is very, very, very important, serratus anterior. It is a serratus anterior. So dorsal scapular, long thoracic, musculocutaneous, axillary nerve. Their muscles are very, very important, that what muscles are supplied by it. Now coming to the clinical aspect, Erb's palsy, we said E comes first, so upper trunk. Erb's is upper trunk and the Klumpke's is lower trunk. If Erb's is upper trunk, nerve root involved C5, C6, deformity is the policeman tip deformity, Vater's tip deformity, also known as Porter's tip deformity. And what is the deformity over here? The position of the limb is in, we say, adduction, extension, medial rotation and the pronation. Very, very important that what is the position of the limb over here. Now as you compare it with the Klumpke's. Now for the Klumpke's we say it is a lower trunk, nerve root involved C8, T1. And what is the deformity? Claw hand. What happens in the claw hand? What happens in the claw hand? At the metacarpophalangeal joint, what movement is there? Hyperextension. Hyperextension at metacarpophalangeal and flexion at the fingers. So that is for the claw hand. So whenever you see the claw hand, you will see that at the metacarpophalangeal joint there is hyperextension. Now it can be sometimes associated with Horner syndrome, and the four main components of the Horner syndrome is meiosis, ptosis, anhidrosis, anophthalmos. A point to note over here that this is anophthalmos, okay, anophthalmos, not exophthalmos, anophthalmos. Now coming to the muscles over here, this image is very important for you. You should be able to identify pectoralis major, pectoralis minor. Okay, these two muscles you should be able to identify. Then apart from this, you should be able to identify this image also, that is for the serratus anterior. Okay, you should be able to identify these muscles. Then apart from this, for the pectoralis major, the action is a combination of what? Like this. What was this? This was flexion, adduction, medial rotation. Okay, we remembered like this: flexion, adduction, medial rotation. And for the serratus anterior, what is the action? Boxer's muscle. It is a boxer's muscle. So punching, pushing, PPP, triple P. Punching, pushing, protraction. Punching, pushing, protraction. So it is helping in the protraction of the scapula, triple P, and it is a boxer's muscle supplied by long thoracic nerve. If any injury to the long thoracic nerve, it will lead to which deformity? This winging of scapula. Again, this image is very important for you. Winging of scapula. So which muscle paralyzed? The nerve gone is long thoracic nerve. Which muscle paralyzed? Yes, serratus anterior. And if serratus anterior gone, what movement affected? Loss of protraction. And due to this, what is happening? The medial border of scapula and the inferior angle of scapula, they have become prominent. Now we say if the protraction is the scapulas are going laterally. Retraction is reunion, scapula's reunion. The reunion of scapula occurs. So we say scapula when it comes near, that is retraction. When it is going away, that is protraction. Retraction is by which muscles? We know rhomboids. So retraction, R for retraction, R for rhomboids. So retraction, rhomboids, both the rhomboids, rhomboids major and the rhomboids minor, as well as which fibers of trapezius? Middle. It is a middle fibers of trapezius. Very, very important. This both actions are very, very important, the protraction and the retraction. Now coming to the deltoid muscle, a very important action, that is the abduction of the shoulder, the abduction at the shoulder joint, which is from 15 to 90 degree, and in fact the whole movement is very, very important. And we say that 0 to 15 degree, that is the initiation, is by supraspinatus, 15 to 90 degrees by deltoid, and more than 90 degrees by both trapezius and the serratus anterior. A very, very important movement, and we very well know that this is the deltoid muscle. Now if the axillary nerve injury is there, so we very well know it can be due to the fracture of surgical neck of humerus or dislocation of the shoulder joint, right? It can be due to this. What will happen? If the nerve is gone, muscle paralyzed is deltoid and the teres minor, right? The nerve is gone, the deltoid is paralyzed. If the deltoid is paralyzed, what action will be affected? Abduction will be affected. So loss of abduction at the shoulder joint, this loss of abduction. And if this loss of abduction, after this what we say? Loss of rounded contour of the shoulder, the round shape of the shoulder. So deltoid gone, then we say loss of abduction, loss of rounded contour of shoulder, and what else? Sensory loss over here. What is this known as? Regimental badge sensory loss. What is the reason for this? We say because the branch of the axillary nerve, that is upper lateral cutaneous nerve of arm, that will be affected. So that is why sensory loss in this position, the regimental badge sensory loss. Now coming to the back region, you should be able to identify all the muscles over here. This image is very important for you. You should be able to identify all the muscles over here. We very well know that this black muscle over here is the levator scapulae. The pink muscle is rhomboides minor, and this blue colored muscle is rhomboides major. Right, these three muscles in the order over here. Then this muscle is the trapezius, and towards the lower side we say that this is the latissimus dorsi. So you should be able to identify all the muscles over here very well. And the levator scapulae, as the name suggests, it is helping in the elevation of scapula. The name is levator. So elevation of the scapula. Very, very important point is, what is the nerve supply of trapezius? Spinal. It is a spinal accessory nerve. Cranial nerve 11. It's spinal part. And it is also supplying which muscle? Sternocleidomastoid, oblique muscle present over here. This spinal accessory nerve is running over here in the neck. If it is injured during any procedure done in the posterior triangle of the neck, it will lead to what? Loss of shrugging. Very good. Loss of shrugging, as well as if the trapezius muscle is paralyzed, it also leads to the dropped shoulder. Okay, dropped shoulder. Now coming to this image. Now this image is very, very important for you. Asked twice. So you should be able to identify all the muscles over here. You should be able to tell supraspinatus above the spine of scapula, infraspinatus below the spine of scapula. At the lateral border, two muscles running parallel, in which we say above is the teres minor and the below one is the teres major. So all the four muscles are very, very important for you. Apart from this, from the anterior aspect, we say that the muscle which is coming from the anterior aspect of the scapula, that is the subscapularis. So these are the muscles which are present over here, and we have already mentioned the rotator cuff, and we say the rotator cuff is a dynamic stabilizer of the shoulder joint, in which the most commonly injured tendon is supraspinatus and the forgotten muscle is subscapularis. Now coming to the intermuscular spaces of the over here, we said that we will memorize two lines only, and accordingly we can answer it. Okay, first is that quadrangular space near surgical neck of the humerus. Okay, which space? Quadrangular space near surgical neck of humerus, and lower triangular space near the shaft or the spiral groove of the humerus. Right. So if you remember these two lines, we say the whatever is the third space, we give that space to the scapula. Whatever third space is there, we give it to the scapula, and whatever structures are related to it, same structures are present in the contents. Over here it is related to scapula, so scapular artery. And then we said triple T, which is forming these spaces: teres minor, teres major, triceps, long head. Okay, triple T. Now as you come to the arm and the forearm, now when you talk about the arm area, the anterior compartment nerve is musculocutaneous, posterior compartment radial nerve. In the forearm, we say the anterior compartment is median nerve, ulnar nerve, and the posterior side we say radial nerve, right? And when you come to the hand, again we say median nerve and the ulnar nerve, median and the ulnar. So now we know that whatever muscles are present on the posterior side, all are supplied by radial. Whatever muscle is present on the anterior side of the arm over here, BBC, biceps, brachialis, coracobrachialis, all are supplied by musculocutaneous. And what is the common action which is done by them? Common action is flexion. So whatever muscles are present on the anterior side, flexors, posterior side, extensor. And when we see the muscles over here, this is a biceps. When you remove the bicep, we say below a small muscle brachialis and above a muscle is a coracobrachialis. And when you talk about the triceps, only one muscle on the posterior side, so it is supplied by radial nerve. What is the action? Extension. It is helping in the extension. Now when you come to the forearm, we very well know median and the ulnar nerve is going to supply it. All the flexor muscles present on the anterior side, right? So what we have said, flexors, pronators. The flexors and the pronators on the anterior side, extensors and the supinator on the posterior side. So we remember only one thing, flexor and the pronator on the anterior side. So all the muscles having the word flexor and the pronator, they are on the anterior side. Palmaris brevis is present in the palm, so it is also on the anterior side. Over here, this image for the muscles is very important for you. When you see this image, we say that the shortest muscle which is present over here, this muscle which is shortest, it is the pronator teres. Then the muscle which is going till the carpi bones or till the wrist, we say the one going on the lateral side is flexor carpi radialis. The one on the medial side is flexor carpi ulnaris. So this one and this one. These are the flexor carpi. The shortest muscle we have already said pronator teres, and whatever muscle is running between it, it is the palmaris brevis. Sorry, it is a palmaris longus. It is a palmaris longus which is present in between. Now coming to this muscle over here, this is the muscle flexor digitorum superficialis, and for this muscle we say that it is going to the digits. Okay, it is dividing and going to the all digits, and it is going till the middle phalanx. So with the help of this, we identify that whatever is going to the thumb, pollicis, whatever is going to the fingers, rest of the fingers is digitorum, whatever is till the wrist is the carpis, that is the carpi muscles. Now as we come over here, whatever muscle is going to the thumb, that is pollicis, flexor pollicis longus, to the rest of the fingers, FDP, and the deepest muscle which is quadrilateral, it is the pronator quadratus, and FDP, it is attached to the distal phalanx. Now over here, very important, the nerve supply. Now we say all the muscles of the anterior side of the forearm, they are supplied by the median nerve. Yes, it is supplied by median nerve. What are the exceptions? Flexor carpi ulnaris. Now this flexor carpi ulnaris is already saying that ulnaris word is there. So it is supplied by ulnar nerve. Okay, the word ulnaris is already there. So we say that it is supplied by ulnar nerve. So it is the only muscle in this compartment which is having the word ulnaris. So supplied by ulnaris, ulnar nerve. One muscle you have to remember, that is the medial half of flexor digitorum profundus. Okay, that is also supplied by ulnar nerve. Now coming to this point, which is a very important point, the pronation and the supination movement. This is a supination and this is a pronation. Supination, pronation. This is at what joint? Radio-ulnar joint. The pronation movement by two pronator muscles, pronator quadratus, pronator teres, and the supination by supinator. As the name suggests, supination is by supinator, and also the biceps brachii muscle. Then we have remembered FM radio. FM radio, we said common flexor origin is at medial epicondyle of the humerus. So FM radio, common flexor origin, medial epicondyle of the humerus. Now another very important point over here is anterior introitious nerve is a branch of. The anterior introitious nerve is a branch of median nerve, and when you talk about the posterior, so everything on the posterior side is for radial nerve. So posterior introitious nerve is a branch of radial nerve. So we said everything on the posterior side radial nerve, median nerve is running on the anterior side like this. And what about the ulnar nerve? The ulnar nerve is running behind the medial epicondyle and it runs on the medial aspect. Okay, so when we talk about the median nerve, it is running anteriorly, and when you talk about the ulnar nerve, it is running on the medial side because it is running behind the medial epicondyle and it is completely on the medial side. Now coming to extensor compartment, in this image is important for you. You should be able to identify brachioradialis, and we know all the extensors are present over here plus supinator. Along with that, you should be knowing these three muscles, brachioradialis, supinator, anconeus, and all these muscles on the posterior side, all supplied by which nerve? All supplied by the radial nerve. All supplied by the radial nerve. For the identification, brachioradialis is important for you. Now coming to the hand, when you talk about the hand, very important point, lumbricals. First and second, median nerve. Third and fourth, ulnar nerve. Very important, very important. And this image is very important for you. You should be able to identify the lumbricals. Counting starts from thumb side. The counting starts from thumb side, 1, 2, 3, 4. Right. Then apart from this, first you remember the lumbricals, first, second, median nerve, third, fourth lumbrical is by the ulnar nerve. And when we talk about all the muscles over here, we say that for the ulnar nerve, third, fourth lumbrical, all hypothenar, all interossei, and then we add into it adductor pollicis. Okay, you add into it adductor pollicis. The nerve supply is very important over here. Then apart from this, we say the palmar interossei adduction and the dorsal interossei is helping in the abduction of the fingers. Now as we come to the anatomical snub box, now as we come to the anatomical snub box, very important, very high yield topic, and this image is very important for you. You should be able to identify the boundaries over here. This is a depression. The red boundary is the medial and the blue boundary is the lateral. You should be able to identify the boundaries in the image. And medial boundary, it is formed by EPL. We say IPL. Okay, IPL matches are there, so EPL, IPL. You remember in any way. First of all, you will remember the medial boundary. Okay, first of all, you will remember the medial boundary formed by EPL, extensor pollicis longus. Then coming to the other boundary, the lateral, and the rest of the two muscles, they are forming the lateral boundary. Extensor pollicis brevis, abductor pollicis longus. So first you remember the medial boundary. Then which bone is present over here? Carpal bone, we know scaphoid. What is the content of this anatomical snub box? Very important, radial artery. So if you feel any pulsation over here at the anatomical snub box, we know that is a pulsation of the radial artery. And if you feel any tenderness at anatomical snub box, so you know that is a fracture of the scaphoid. For the flexor retinaculum, we know it is present at this location. So what is present deep to it? Very important. Everybody knows median nerve. The median nerve is present deep to it. What tendons? So tendons, we say tendon of FDS, FDP, FPL. Whatever tendons are going into the fingers and the thumb, they will have to cross this point. So FPL to the thumb and the FDS and the FDP, which is going to the fingers. So by this you can remember that these are the tendons passing deep to this flexor retinaculum. Now as you talk about the compression of the median nerve in the carpal tunnel, we say it is known as carpal tunnel syndrome. If you compare it with the cubital tunnel syndrome or the Guin canal syndrome, which nerve compression? Ulnar nerve compression. That is the ulnar nerve compression. Now for the carpal tunnel syndrome, a very specific point, like if any clinical question is given to you, a very specific point for you is tingling sensation in the distribution of median nerve. It is a tingling sensation in the distribution of median nerve. And what is the distribution of median nerve? Lateral portion, the lateral 3.5 of the palm area. The lateral 3.5 word you will remember for the median nerve. This is very important for the median nerve. Lateral 3.5, lateral 3.5 median nerve, lateral 3.5 median nerve. The rest of the portion ulnar nerve. And what is the test for the carpal tunnel syndrome? This is the Phelan's test. This is a Phelan's test. Now coming to the cubital fossa, we say which muscle is forming the medial boundary. So on the medial side we say is the pronator teres, and on the lateral side we say is the brachioradialis. Then we say that there is a vein which is present over here, median cubital vein, which is a very frequently asked question, that which vein is most commonly used to take the intravenous blood samples or for giving intravenous drugs. So that is the median cubital vein, and that is a very superficial structure, superficial to the bicipital aponeurosis. Now when you talk about the contents of the cubital fossa, what is the mnemonic? The mnemonic is MBBS. Okay, the mnemonic is MBBS. Medial to the lateral, median nerve, brachial artery, biceps tendon, superficial branch of radial nerve. So when you see this image over here, from medial to the lateral, This nerve is median nerve, then the brachial artery, biceps tendon, and the superficial branch of the radial nerve. So for the cubital fossa, we remember MBBS. Okay, MBBS for the contents: medial boundary, pronator teres, lateral boundaries by brachioradialis. Now, as we come to the nerves, we say median nerve and the ulnar nerve. Median and the ulnar nerve, they don't give any branches in the arm area. And when you come to the median nerve, for the median nerve, we say one of its branch is anterior-anterocious nerve, and this is going to supply what? It is going to supply the deeper muscles. Which deeper muscles? FDP, FPL, and the pronator quadratus. So we very well know, and we have already mentioned the sensory supply also, lateral 3.5, and this image is important for you. This is important for you to learn, okay, to remember, to learn the sensory supply in the hand. So in the palm area, we say that lateral 3.5 portion, so counting always from the thumb side, lateral 3.5, this is on the lateral aspect, so lateral 3.5 portion supplied by median nerve, and the rest of the portion by ulnar nerve. On the posterior side, the ulnar nerve area is the same, but the median nerve is supplying only the nail beds of the lateral 3.5 area or the fingers, and the rest of the portion on the lateral side is supplied over here by radial nerve. It is supplied by radial nerve. This sensory supply is very, very important for you to remember, because if there is any question on the nerve palsies, it will be helpful. And for the median nerve, starting with the median nerve, what we said, it is a guru of all. Okay, it is a guru of all. Median nerve is the BAP. He is a BAP of all. So B, benediction deformity, A, ape thumb, P, pointing index, and another P is the pen test. And because the median nerve is supplying the majority of the thenar muscle, like you will see that the thenar muscle group is affected. Thenar atrophy, thenar wasting, reduced thenar eminence. So when the thenar word is there, that is for median nerve. And we say that along with that, sensory laws in the distribution of the nerve. These are the basic deformities which are present, and if any deformity is given to you, by the looking at the deformity, you should be able to identify. Thumb, if it is like brought close to the hand, that is the ape thumb. If the hand is in this position, that is the benediction deformity, and if they put the hand in this position with the index finger pointing, that is the pointing index. Then the pen test you are having for median nerve, and this is the image which is showing the pen test. So in the pen test, basically you are trying to check the abduction of the thumb. Now when you talk about the ulnar nerve, for the ulnar nerve you will remember one deformity, 3 tests. The median nerve, 3 deformity, 1 test, and for the ulnar nerve we say 1 deformity in the 3 test. What is the deformity over here? Partial claw hand, and partial claw hand is the clawing of which 2 fingers? The clawing of medial 2 fingers, and this image is very, very important for you, medial 2 fingers. And along with that, which muscle group affected? Hypothenar. Okay, it is a hypothenar. Now over here, hypothenar muscle group is affected because it is completely supplied by ulnar nerve, along with the sensory loss in the distribution of the nerve. So this is for the ulnar nerve. In this we say only one deformity, partial claw hand. As then apart from this, we say that what are the tests over here? The test is book Froment test, card test, paper test, or Igawa test. These are the 3 tests which is for the ulnar nerve. When you talk about the complete claw hand, both median and the ulnar nerve, they are affected. Now coming to the radial nerve. In the radial nerve, very important over here, above the spiral groove, branch to the triceps. Within the spiral groove, branch to the triceps and anconeus. Below the spiral groove, branch to the brachioradialis and the ECR. Apart from this, all other muscles, they are supplied by posterior introitious nerve. So the posterior introitious nerve is the one which supplies the rest of the muscles of posterior compartment of forearm. Right. And now when you talk about the radial nerve injury, one point you have to remember always, wrist drop. Okay, wrist drop is always there. And it is associated with the crutch palsy. There is a compression of the radial nerve in the axilla, or it is associated with the Saturday night palsy, in which there is a compression of the radial nerve in the spiral groove. in the spiral groove. Now, very important over here when we talk about the arteries, very important. First of all, you should be able to tell what are the three branches of arch of aorta. What are the three branches of arch of aorta? Very well we know it is a brachiocephalic, left common carotid, left subclavian. Okay, it is of the left side. The left side branches are directly coming from arch of aorta, and when you talk about the brachiocephalic, it is further giving off the right subclavian and the right common carotid. Okay, so it is, just a second over here. So the brachiocephalic is giving off the right subclavian and the right common carotid. So these are the three branches coming from arch of aorta. The first and the foremost thing you should be knowing these three branches. Then as we talk about all the arteries over here, we say very important is the subclavian artery and the axillary artery, and you should be knowing its branches. When you talk about the branches over here, the subclavian artery, it is crossed by which muscle? Scalenus anterior. And what is the branches? Branches for that we remembered with the help of mnemonic VIT, C, D. VIT for the first part, C for the second part, D for the third part. What is VIT? Vertebral artery, internal thoracic artery, thyrocervical trunk. And the thyrocervical trunk again giving sit, suprascapular, inferior thyroid and the transverse cervical. So take vitamin C, D and sit comfortably. Okay, take vitamin C, D, sit comfortably, your subclavian artery will be fine. Your upper limbs are going to be very good. So vitamin C, D and sit. And VIT, SIT, all are the branches coming from first part. C, costocervical from second part. D, dorsal scapular from the third part. And when you are identifying the arteries, we mentioned the first part, any artery going down, internal thoracic, any artery going straight up, vertebral artery, then third artery which arises and then it again branches, that is the thyrocervical trunk. The branch which is going towards the neck is the inferior thyroid artery. The rest of the two branches are going laterally. Now as you come to the axillary artery, it is crossed by a muscle pectoralis minor. And what are the branches? The branches for that we had a very interesting mnemonic, slap the lion, save a person. So now you have to save yourself. So slap the lion, save a person. Slap for the first part, the rest of the two, the lion for the second, and the rest of the three words for the third part. So we say superior thoracic artery from first part, lateral thoracic, thoracoacromial second part, subscapular and the anterior and the posterior circumflex humeral from the third part. And when you are identifying the arteries, lateral thoracic artery identification very important. Any artery running along with the pectoralis minor is a lateral thoracic artery, and the one which is keeping a watch on it, and we say that is running parallel to it. So this third branch which is running parallel to it, this is the subscapular artery. This is the subscapular artery. So these two arteries are the most important to identify, and from the first part only one branch coming, so we know that is superior thoracic. The second part we have identified lateral thoracic, and whatever another branch is coming from it, that will be thoracoacromial. Okay, if this is a lateral thoracic, any other branch coming from the second part is a thoracoacromial. Third part, if this is a subscapular, whatever branches are going laterally, on the lateral side, the two branches will be present in the form of a circle because they are anastomosing with each other. So that is anterior and the posterior circumflex humeral. Now coming to the anastomosis, you should be knowing it is between which parts. So we say first part of subclavian and the third part of axillary. Okay, so initial most part of subclavian and the last part of axillary. What are the arteries which are participating over here? So how you remember, all the arteries if you see are scapular arteries, scapular, scapular, scapular. Whatever arteries are having the word scapular, all are coming over here. You have to remember only one, and that one is transverse cervical artery. Okay, you have to remember only one, transverse cervical. So these are the arteries which are participating over here. Regarding the lymphatic drainage, most important is axillary lymph node, anterior group of axillary lymph node, which is the chief lymph node draining the breast tissue. And this anterior group of axillary lymph node is related to which vein? It is related to the lateral thoracic vein. Whatever points I have highlighted over here in the workbook, In the same way, you can also highlight in your workbooks. Many of the points must be highlighted already in your workbooks during the class. If you find any other point, you can just highlight. So what will be there? After watching this video, like if you want to do again a quick revision and quickly you want to just revise that what were the main points, you can just go through the pages and see those highlighted points, right? Now coming to the levels of the axillary lymph node, on the basis of which muscle do you divide? Pectoralis minor. And how do you divide? The level 1 is below. We say level 1 is below and lateral to the pectoralis minor. Level 2 is deep to it. Level 3 is above and medial to this muscle. Now coming to the dermatomes, very important for you. Please, all of you all should be knowing dermatomes. How will you remember? Upper limb. For the upper limb, the dedicated dermatomes are C5 to T1. Okay, C5 to T1 is devoted or dedicated for upper limb. It is dedicated for the upper limb. So we say C5 to T1, it is for upper limb. And how we say C5 to T1? For the C5 to T1, we say it is like this. Okay, it is like this. C5, C6 going to the thumb, middle 3 fingers C7, starting from the little finger C8 going over here, and T1. And the T2 is coming in the axilla. So when you are remembering the upper limb dermatomes like this, then the thoracic dermatomes going down in the trunk, they present in the trunk like this till this point, and we say that at the level of umbilicus the dermatome is T10. So for the thumb it is C6 and for the umbilicus the dermatome is T10. And when you finish the thoracic dermatomes over here, the lumbar and the sacral to the upper limb, the lumbar and the sacral is towards the lower limb, and the lumbar on the anterior side, sacral on the posterior side of the lower limb. So C5 to T1 upper limb like this, thoracic segment simply counting down, lumbars on the anterior aspect of the lower limb going down, and the sacral on the posterior aspect of lower limb going up. So in this way you will remember all the dermatomes. Then apart from this, the vertebral level of the umbilicus is very important over here. What is the vertebral level? L4, or we say the best another answer is the junction of L3 and L4. Any of them can be given. L4 is the first best answer, and we say that more commonly the junction of the L3 and L4 is given in the options. So the dermatomes I am speaking again over here for the upper limb C5 to T1. You remember like this, thoracic going down and lumbar on the anterior aspect of the lower limb going down, and the sacral on the posterior aspect of lower limb going up. Now in the x-rays over here, you should be able to identify all these landmarks which we have mentioned earlier also. You should be able to identify coracoid process, that this is a coracoid process, this is the acromion process, then in the humerus, surgical neck, shaft of the humerus, and this is the greater tubercle. All these landmarks are important for you, and this x-ray is important for you. Okay, this x-ray is important for you. Then apart from this, in this x-ray you should be able to identify olecranon process and this radial tuberosity. Then another x-ray which is important for you is for the hand, and you should be able to identify all the carpal bones over here. Okay, you should be able to identify all the carpal bones, which is exactly the same way we have identified in the another image. Over here we say that when you are seeing the carpal bones over here, in the proximal row, the pisiform and the triquetral, they are overlapping each other, so no separate shadow for these two bones. For other bones, the separate shadows can be seen. Now one more point over here, very important point, coracoclavicular ligament. It is the one which helps in the weight transmission from upper limb to the body. So which ligament is this? Coracoclavicular. Okay, it is coracoclavicular. Now coming to the joints, very important and high yield topic. In the joints, one question is always expected, and when we talk about the joint, we say fibrous, cartilaginous or synovial. Okay, these three joints we will be discussing. Now what are the main joints? For the fibrous joint, sutures in the skull. What is over here? Teeth in the bony sockets, it is the gum fosses. And very important over here, syndesmosis. Please always remember syndesmosis. Syndesmosis, what is the location? Middle radioulnar joint. This is a middle radioulnar joint over here, and this is the syndesmosis. When you talk about the superior and the inferior radioulnar joint, this is pivot variety. Both are pivot variety. So when we are talking about the fibrous joint, syndesmosis is the most important, and the most important example is middle radioulnar joint. For the cartilaginous, divided into primary and the secondary. The primary is also known as synchondrosis and the secondary is also known as symphysis. And when we are talking about the most important example over here, synchondrosis or the primary, you will remember first costosternal joint. And for the secondary cartilaginous, it is the pubic symphysis. So we have already mentioned this pubic symphysis. This bony pelvis image is very important for you. You should be able to tell that this is the location of the pubic symphysis. Now, as we come to the synovial joints, very, very important for the upper limb. Whatever joints in the upper limb, you should be knowing their variety. When you talk about the hinge joint, in the hinge joint, we say what are the examples? Elbow joint and the interphalangeal. Okay, elbow and the interphalangeal. Then we say the most important over here is the pivot variety. What is the example over here for the pivot variety? For the pivot variety, we say superior radioulnar and also inferior radioulnar, we have just mentioned. So superior and the inferior radioulnar pivot variety. Another is atlantoaxial joint. The atlantoaxial joint, we say it is between C1 and C2, and this is also known as no movement joint because the rotational movement are occurring over here between C1 and C2. So this is a no movement joint. This is the most important synovial joint over here. Whenever you are memorizing the synovial joint, first of all, you will remember the pivot, right? Pivot you will remember first of all. Then another example is ellipsoid, which is present at the wrist joint. First carpometacarpal joint is the saddle. It is a saddle over here. Then as we come to condylar, in the condylar you are having main examples temporomandibular joint and the knee joint. Then apart from this, we say for the metacarpophalangeal joint, we have mentioned both in condylar and the ellipsoid. And the first best answer we say is the condylar, also included in the ellipsoid. So over here, whatever these main joints are there, you should be very well knowing. Now coming to the parts of the growing long bone, these are all the parts of the growing long bone: epiphysis, epiphyseal or the growth plate, metaphysis, diaphysis, in which we say that epiphysis, it is going to form the ends, and the diaphysis, it is going to form the shaft. And when we are talking about the types of epiphysis, what are the types of epiphysis? Pressure, traction, atavistic and the aberrant. Now when you talk about the pressure epiphysis, for the pressure epiphysis, what we said, weight transmission. Any bone which is having relation with the weight transmission is pressure. You're putting some pressure on those bones. So when you talk about the pressure, you say knee joint is taking all the pressure of the body. So whatever joints are present near the knee joint, lower end of femur and upper end of tibia, they are the pressure. They are having a lot of pressure from the body. So pressure epiphysis, as well as at hip joint also, all the pressure of the body is coming. So we say also the upper end of the femur, right? And when you talk about the weight transmission from the upper limb, we say it is this point and this point. So this point, this point. This point is over here we say lower end of radius, and over here we say upper end of humerus. So these are the other points which are related to the weight transmission. Whenever you talk about the traction epiphysis, it is related to the muscle attachment. Okay, it is related to the muscle attachment or the muscle pull. So we have tubercles, the greater and the lesser tubercles of humerus, and the greater and the lesser trochanter of the femur, as well as this process, mastoid process. For the atavistic, we said what is the main example? The main example is coracoid process of the scapula. This is the atavistic epiphysis. Aberrant is head of first metacarpal. Okay, it is a head of. Aberrant means abnormal. The abnormal location is there. When you talk about the normal location, that is different. But over here, it is the abnormal location known as aberrant epiphysis. So whenever the question is given on the epiphysis, you should be basically able to differentiate in the options. All the options will be given from this list only, and you should be able to differentiate that which is the pressure, which is the traction, which is the atavistic, and which is the aberrant. Now coming to the hybrid or the composite muscle, dual nerve supply. So we say what is a mnemonic? BP is bad for the students. Yeah, is it true or not? Yes, it is true. And now you have to actually manage your anxiety and all the BP also. So we say BP bad for the students. Of course, it is bad. And what is there? B is brachialis, P is pectoralis major, pectineus, B is biceps femoris. It is femoris of the lower limb. A is adductor magnus, D is the digastric, F is flexor digitorum profundus and the flexor pollicis brevis, T is trapezius, S is subscapularis. So all these muscles are the hybrid muscle, and all these muscles you should be knowing. Okay, all the names you should be knowing. So that is why we are having this mnemonic over here. Okay, now coming to the thorax area over here. Now coming to the thorax area over here, very, very important, what is the vertebral level? Now you know that the vertebral level is also commonly asked nowadays, so you should be knowing all these vertebral levels. Vertebral level for the sternal angle or the angle of Lewis. It is what? T4. First of all, you remember it is T4. And when you talk about T4, we say which border of T4? It is the lower border of T4. Okay, it is the lower border of the T4. This is the first best answer. If it is not given, then you can go for junction of T4 and T5. So lower border of T4. This is the sternal angle or the angle of Lewis. Now, a very, very important clinical point over here when we are talking about the pleural tap. So you should be knowing that the needle is put where? Very important point. Very frequently asked question. Yes, very correct. Along the upper border of the rib. Okay, put the pleural tap needle along the upper border of the rib. Now coming to the mediastinum, we know at the level of T4 we divided into superior and the inferior. Then the inferior is divided on the basis of the heart. The heart is present in the middle mediastinum. Whatever space is in front of it is anterior. Whatever space is behind it is the posterior mediastinum. And when we are talking about the contents over here for the superior mediastinum, we remember two tubes. Okay, what are the two tubes? Muscular tubes, trachea, esophagus. Two tubes, trachea, esophagus, two vessels, arch of aorta with the branches and the superior vena cava. Four nerves, phrenic nerve going to the diaphragm, vagus nerve running along with the esophagus, sympathetic trunk and left recurrent laryngeal nerve. The left recurrent laryngeal nerve taking a turn, U-turn at arch of aorta. Four nerves and two more structures, thymus, thoracic duct. So we remember like this, two tubes, two vessels, four nerves and two other structures, thymus and thoracic duct. Coming to the posterior mediastinum, we say, how do you remember? By the mnemonic EDTA salt. Okay, you remember the mnemonic EDTA salt first of all, and then E is esophagus along with that vagus nerve, D is the descending aorta, T is the thoracic duct, A is the zygous venous system, S is the sympathetic trunk. So over here, as you remember all the mnemonics, you will find that you are able to memorize, a lot of portions very quickly. Now coming to the heart, which is a high yield topic itself, apex is formed by left ventricle. It is formed by the left ventricle, we very well know. And what is the location? The location is important in which space? Left fifth intercostal space. Left fifth intercostal space. Base, for the base we said we had this mnemonic. We remember by this mnemonic the base is by both atrium, the right and the left atrium. And in the atrium also we say mainly it is by the left atrium. So the apex is by the left ventricle, base, the mnemonic of the base is base itself, both atrium. As you come to the surfaces, we say anterior surface or the sternocostal surface. So all the chambers of the heart are present on the anterior surface, right atrium, right ventricle and the left ventricle, except which one? Left atrium. The left atrium is completely on the posterior side. So we say that anterior surface is by three chambers except the left atrium. And what about the inferior surface and the diaphragmatic surface? For that we say heaviest chambers. What are the heaviest chambers? Both ventricles. So according to like weight, you can say, just to remember, this is just to remember, the heaviest chambers, they settle down. The heaviest chambers are ventricles, they settle down and they are resting on the diaphragm. So we say inferior surface or the diaphragmatic surface, both ventricles. Now in the right atrium, you are having these specific structures: fossa valis, annulus ovalis, torus aorticus, only in right atrium, only in the right atrium. And when you talk about the chorda tendineae and the papillary muscle, it can be present in both the ventricles. Now very, very important over here, very, very important, origin of right coronary. The origin of right coronary, when you are talking about the coronary arteries, you will remember for right coronary. If you remember for the right coronary, the another one you will remember automatically, because another one will be the opposite. So if I say right coronary taking origin from anterior aortic sinus, it is taking origin from anterior aortic sinus. The left coronary is taking origin from posterior aortic sinus, opposite of that. And which posterior aortic? Left. So left for left. The left is for left. Left posterior aortic sinus gives origin to the left coronary artery. So very important, right coronary taking origin from anterior aortic sinus. Right. Now another thing, when you are talking about the branches, so which branch you will remember first? We said the first branch you are going to remember is this artery. What is this? Posterior interventricular artery, for which we say is an important branch, PIVA. So for the right coronary artery, we say it is a posterior interventricular artery. It is a branch of the right coronary. And if you remember this, if you remember this right coronary branch, that its branch is posterior interventricular, then opposite of this, that is the anterior interventricular, it is a branch of left coronary. Okay, so like as I am revising over here in the workbook, you go along with me, along with this speed only, and you can just quickly go through it, and you will in the end you will be able to like understand that you have grabbed a lot of points. And then you can just in the evening you can quickly again go through your workbook, and you will find that a lot of points you have already memorized. There will be few points which you are not able to memorize, so for that you will have to put the effort. And for that also, what you can do, like if you whenever you are revising, there will always be some points which you are not able to remember perfectly, or which you are forgetting again and again. So on the last page of the workbook, you can just write the page number, that this page number, a point is there, that which you are not able to memorize. Or you can use those colored paper tags. You know, you had not that on the page you can stick those colored sticks, paper sticks. So you can just put the stick over there, paper stick, so that you remember that this is a point which is I'm forgetting again and again. So whenever you see the workbook, you can just go through those points quickly, and those points will be less, of course, which you keep forgetting, which you say na, that I keep forgetting this point or that point. Those points are actually less, they're not more. You have memorized a lot of things. At this point of time, you don't realize this thing, but I'm telling it to you. You have memorized a lot of things, but the time now is that you have to be on the, you have to keep walking on this track. Whatever track you are following for this much time, you have to keep going on this track. If you keep going like this only on the track, nobody can stop you. You will win the race and you will clear the exam. Nobody can stop you. So over here we say the posterior interventricular artery, it is a branch of right. We remember for this. Okay, we remember for this. If the posterior is for the right, the anterior interventricular is for the left coronary. Then apart from this, over here we say the anterior descending artery. This is actually the left anterior descending. The left anterior descending and the left circumflex. As the name is coming over here, left, left. So the name is itself suggesting that these are the branches coming from the left side. So these two are coming from the left coronary, as the name suggests, left. The most important branch, PIVA, posterior interventricular artery. Now this is also helping us to decide the cardiac dominance. The cardiac dominance, we know we have right cardiac dominance because the PIVA is arising from right coronary. But there are few individuals in which the PIVA can arise from the left side. And if it is coming from the left side, we say it comes from left circumflex artery. It is coming from left circumflex artery. When you see this image over here, this is the right coronary and this is the left coronary, dividing into this branch which is left circumflex, and this one is the anterior interventricular. Okay, this is the anterior interventricular. The right coronary, when it is finishing at that point, it gives a branch over here which is the piva. Okay, this branch is the piva. So these are the branches which are given off by the right and the left coronary. Now when you are talking about the venous drainage, for the venous drainage we very well know that the venous sinus which is important for us is the coronary sinus, which is present on the posterior aspect of the heart over here at this location. The location we very well know is the coronary sulcus over here, and we say all the veins they drain into the coronary sinus except which vein? Now what is the exception over here? The exception is anterior cardiac vein. So we say all the veins of the heart they drain into the coronary sinus except which one? Exception you should be knowing, anterior cardiac vein. The coronary sinus will also drain into the right atrium. The anterior cardiac vein is also going to drain into the right atrium because all the venous blood finally goes into the right atrium. But over here we say that anterior cardiac vein directly drains into the right atrium. Now coming to the angina, we say the pain is referred into which area? T1 to T5 dermatomes, and as well as one more nerve is participating in the referred pain, that is the intercostobrachial nerve. The intercostobrachial nerve is a branch of T2. Now as we come to the trachea over here, we have underlined this point, lower border of cricoid cartilage, that is C6. Okay, we have mentioned earlier C6 is an important landmark. It is present at the lower border of cricoid cartilage. C6 is a landmark where pharynx and the larynx ends and the trachea and the esophagus begins. So at all this we mentioned the C6, larynx and the pharynx ending at the C6 and the trachea and the pharynx beginning at the C6. Now for the trachea, very important is its transverse section. In the transverse section we know on the anterior side it is having the C-shaped hyaline cartilage, and posteriorly it is filled by what? It is filled by a muscle which is trachealis. So posteriorly it is filled by a muscle which is trachealis. Now when we are talking about the trachea and the bronchus, for this we say that the hyaline cartilage is present only in the trachea and the bronchus. Now when you are talking about the surface marking, you will just remember lung 6, 8, 10. So 6, 8, 10, anterior to the posterior, anterior, lateral, posterior, 6, 8, 10. It is for the lung, and pleura you will just add 2 in that, so 8, 10, 12. So we just remember lung 8, 10, 6, 8, 10, lung 6, 8, 10, lung 6, 8, 10, that is all. We remember lung 6, 8, 10. Then in the lung, we very well know that on the left side of the lung, you are having the cardiac notch as well as a lingular projection, and specifically where they are present in the upper lobe. They are present in the upper lobe. When you are talking about the hilum, what you will remember only this. BABV is right side, ABV left side. That's it. You remember this. So the arrangement of the structures from above to downwards. From above to downwards, BABV right side. Remove B from above, you have only ABV which is on the left side. So BABV right, ABV left, BABV right, ABV left. And if you remember the mnemonic, you can tell the arrangement also yourself, bronchus artery again, what is B vein. And if you remember the mnemonic, you can also tell what is the superiormost structure. So BABV right side, so bronchus is the superiormost structure, and on the left side the artery will be the superiormost structure. So only remember the mnemonic over here, BABV right, ABV left. And very important point over here is what is the structure which is arching over the hilum? Which structure is arching over the hilum? Right side. On the right side it is azygous vein, on the left side it is arch of aorta. Very important point. Okay, this is very important point. On the right side it is azygous vein, on the left side it is arch of aorta. Bronchopulmonary segments, they are 10 on each side, 10 on right side and 10 on left side, and we are having different characteristics. We say it is pyramidal in shape. It has everything of its own except what structure? Except pulmonary vein. The pulmonary vein, we say it runs between the two segments. The pulmonary vein, we know, if we see the two segments over here, we say that the pulmonary vein is running between the two segments. So that is why we say it runs in the intersegmental area. We say it runs in the intersegmental plane, or we can say it is running in the intersegmental area. and the segmental dissection can be done with the knowledge of this. So very important point, pulmonary vein is in the intersegmental area. Another, what bronchus is present at this level, it is the tertiary bronchus. Okay, tertiary bronchus at this level. Then the foreign body aspiration, if the supine position is there, which is more commonly asked, we say it is the apical bronchopulmonary segment of right lower lobe. Now over here, if you observe, it is right lung in which the aspiration is more common, and more you will see it is always right lower lobe. Okay, right lower lobe. Only the bronchopulmonary segment is different. For the supine position, it is the apical bronchopulmonary segment, and when the standing position is there, then it is a posterior basal bronchopulmonary segment. So these segments you should be knowing, and again this is of right lower lobe. This is also of the right lower lobe. So you should be knowing in the foreign body aspiration, more common for supine position, and as well as you should be knowing for the standing position also. Now as you come to the esophageal constrictions, the esophagus, again you see it is starting at this point, it is mentioned at C6, we just mentioned C6 over here, and the location of the constrictions is very important for you, you should be knowing it. First is at the beginning, cricopharyngeal junction. Second, crossing by arch of aorta. Third, crossed by left bronchus. Fourth, passing through the diaphragm. And we say A comes first, B comes after this. So our aorta is above, second constriction, bronchus is the second constriction. Then after this we say what are the distances. So distances is 15, 23, 28, 40 in centimeter, 6, 9, 11, 15 in the inches. These distances also you should be knowing. So first of all, when you are talking about the esophageal constrictions, first you will remember location, most important. After that you will remember the distance in centimeter, and after that you will remember distance in inches. Most commonly they ask about the location. Second, most commonly they ask about the distance in centimeter, and then they can ask, or they can also give you a question on the inches. Now coming to the diaphragm, supplied by a nerve which is the phrenic nerve. Very important over here, phrenic nerve, what is the root value? C3, C4, C5. And you know what we actually talk about in the diaphragm is the major openings. Voice of America. Whenever you are remembering the mnemonic VOA or Voice of America, anterior to posterior, VOA 8, 10, 12. 8, 10, 12 is the vertebral levels. Okay, it is the vertebral levels. So these three openings from anterior to the posterior side, this is the order, and these are the vertebral levels, 8, 10, 12. So when you see this image, in the image you very well know, first of all let us see the schematic image. Whatever portion is shown in the center of the diaphragm, that is a central tendon. This is a central tendon. Another thing, you see the projections. Whenever you see the image of diaphragm, you see some, at one point there is tail-like projection. That is a posterior side, and therefore it is the anterior side. In the center, central tendon. Between the tail-like projection, the tail-like projection known as crus, and between the tail-like projection, this is a median arcuate ligament. The rest of the part of diaphragm is known as muscular part. So when you see this image over here, we can say this is a tail-like projection, crus, this is a median arcuate ligament. The green area is the central tendon, the brown area is the muscular part. This is the posterior side, this is the anterior side. So starting from anterior to posterior, when you go in the image from anterior to the posterior, VOA, whatever three openings, three structures you see passing through, we say VOA. Vena cava opening over here in the central tendon, esophageal opening in the muscular part, aortic opening behind the median arcuate ligament or between the two crus. So you should be able to tell the location over here. And when we talk about the structures passing through it, vena cava opening, of course inferior vena cava along with right phrenic nerve. Then esophageal opening, of course esophagus along with that vagus will be there, and esophageal branches of left gastric artery. Esophagus is there, so of course whatever other structure is there related to esophagus, gastric, stomach. The esophagus is continuous with the stomach, so the other structure is related to it. So we say left gastric artery, its branches. Very, very important, aortic opening. Very important over here. Aortic opening, we say what are the structures passing through aortic opening? Mnemonic is aorta itself. A or ta. So A is aorta, T is thoracic duct, A is azygous vein. These are the most commonly asked structures passing through aortic opening. So if you remember the mnemonics over here, aorta, if you just remember the mnemonic, and if the question comes in front of you, you will be able to definitely answer the question. Okay, I'm not saying that just remember the mnemonic. I'm saying that if by chance, like when you are memorizing that what we're recalling, trying to recall, if you remember the mnemonics well, you will be able to recall the mnemonic, and that will quickly help you to answer the question. Now coming to the thoracic duct, first of all, in this image, you should be able to identify this image. You should be, I'm taking this image is important for you. You should be able to identify this thoracic duct over here. The vein is azygous vein. The artery shown over here is a descending aorta. Very, very important point over here. What is the point where the thoracic duct is draining? So we say drains at the junction of left, it is the left internal jugular and the left subclavian vein. Okay, it is the junction of these two veins. Then as we talk about the veins, as we talk about the veins over here, we say the superior vena cava. We say the superior vena cava over here, how it is formed. So when you see the superior vena cava, you can see it is formed by the union of right and the left brachiocephalic vein. Fine. And for the brachiocephalic vein, it is formed by the union of internal jugular and this subclavian vein. This is on both the sides. This is the basic formation of superior vena cava, but this is a very important point for you. Formation of superior vena cava by right and the left brachiocephalic vein, and the brachiocephalic vein is formed by internal jugular and the subclavian. Then a very important vein over here, azygous. It drains where? It drains into the superior vena cava. So azygous vein, very important. It drains where? It drains into the superior vena cava. Azygous vein present on the right side. On the left side, you have hemiazygous, above accessory, below hemiazygous vein. And they also cross the midline and finally drain into the azygous. Right? This you should be knowing. Then apart from this, for the posterior intercostal veins, right side azygous vein is dominant. So we say 2 to 12, 2nd to 12th, they drain into the azygous. The first directly into the brachiocephalic. This is on the right side, because the azygous vein is dominant. So all the veins, intercostal veins are coming to it. And on this left side, we divide it into 3 groups, upper 4, middle 4 and the lower 4. The upper 4 over here we say are draining directly into the brachiocephalic, middle 4 accessory hemiazygous, lower 4 hemiazygous. Over here, very, very important, azygous vein drains into superior vena cava. Okay, now we will be starting with the revision of head and neck. Now when we talk about the head and neck, all the mnemonics, just give me a minute over here. All the mnemonics over here, whatever we have memorized in the head and neck, all are important for you. As I told you, when you are memorizing, what you can do, the mnemonics, if you are not able to remember, choose any one page. Like there are blank pages also, you can take the front page or in between whatever page is there in the workbook which is blank. You choose that one page and you start writing like this. Sulfopams, it is for what? External carotid artery, page this. Then COPS 3977, this is for parasympathetic ganglia, page number this. Then you write third point, SOS, it is for what? Ansa cervicalis, page number this. So basically you should be knowing that what mnemonics you are having and this is for which topic, right? And page number we are just writing over here so that if you have any, if you're not able to recall anything or you want to see the detail of that mnemonic, you can quickly go to that page number. One time effort, but it will be helpful for this complete 2 months. Okay, whatever 2 months, like exactly like today is exactly after 2 months or less than 2 months, I can say 1 or 2 days, less than 2 months, you will be having your paper. So in this whole time period, one time you do this effort, and this will be helpful till the end, the last day of the, we say that till the last day, it will be helpful for you. So now coming to the head and neck over here. Now for the head and neck, first of all, the skull. In the skull, bregma anteriorly, lambda posteriorly. Bregma is a fontanelle which is present anteriorly between the frontal and the parietal bone, between which sutures it is the sagittal and the coronal suture. Okay, between this sagittal, this is a sagittal and this is a coronal. And when you talk about the lambda over here, that what is the location of the lambda? The lambda location is over here between the parietal and the occipital bone, between at the junction of sagittal and the lambdoid sutures. You should be able to localize it. And when we are talking about the fontanelles, we say there are 6 fontanelles in which the bregma is the last one to close. What is the time of closure? The time of closure is important for you. It is 12 to 18 months. Okay, it is 12 to 18 months. When you talk about the lambda, it is 2 to 3 months. It is 2 to 3 months. The bregma, the closure is very, very important, that when it is closing, 12 to 18 months. Then in the lateral view, this is very, very important. That is a pterion. You should be able to identify the pterion, this landmark over here. And what structure is lying deep to it? Deep to it, we know that the structure which is lying is middle meningeal artery. Okay, it is a middle meningeal artery which is lying deep to it. Now coming to the foramens. In the foramens, very important, foramen rotundum, foramen ovale, foramen spinosum, jugular foramen, as well as supraorbital fissure, which we will discuss later, page number 74. These are the foramens which are most important for you. Okay, these are the foramens which are most important for you. When you talk about the cribriform plate, we know it is giving passage to first cranial nerve, optic nerve, supraorbital fissure we will discuss in detail. When you talk about ovale, for that we are having the mnemonic male, foramen ovale, male, and male is mandibular nerve. Okay, male is mandibular nerve. Then you are having A for artery. The artery is accessory meningeal artery. L is lesser petrosal nerve. E is emissary vein. So these are the structures which are passing through the ovale. And if the mandibular nerve is passing through ovale, we say what is passing through rotundum? What is passing through the rotundum? The structure passing through rotundum is maxillary nerve. The structure passing through rotundum is maxillary nerve. So foramen ovale, male, rotundum, maxillary. So foramen ovale, male, mandibular nerve, and rotundum, maxillary nerve. And if we say these are the three structures, these are the structures passing through it, then we say spinosum. Spinosum gives passage to the middle meningeal artery. So these 3 foramens very important for you: ovale, rotundum, and spinosum. Another is the jugular foramen, and in that we say that 3 cranial nerves, 9, 10, 11. This is very, very important. What cranial nerves? 9, 10, 11. These are the 3 cranial nerves which are passing through it. Then another structure is jugular, internal jugular vein. These are the important structures over here. So these are the 4 foramens which are very, very important for you. Apart from this, internal aquestic word is there. So cranial nerve 7 and 8. Hypoglossal nerve. Over here, the passage of the cranial nerves is the main. So we are mentioning mainly the cranial nerves over here. And we said foramen ovale, male, mandibular nerve, maxillary nerve passing through rotundum, middle meningeal artery passing through spinosum, and the jugular foramen we said 9, 10, 11. Then as we come over here for the foramens, we have mentioned this point that these 3 foramens, they are present in this order. Okay, so first of all, whatever round foramen you see, that is the rotundum. Whatever round foramen you see, that is the rotundum. Whatever oval shaped foramen you see is the ovale, and whatever pinpoint foramen you see, a very small foramen, that is the spinosum. So ROS, it is, we remember by the this mnemonic over here, rows. They're present in a line. ROS, rows. So rotundum, ovale, spinosum. Now coming to the orbit. Now when you're talking about the bony orbit, how do we memorize it? You must be remembering it very well. First of all, we say that it is pyramidal in shape. Okay, it is pyramidal in shape. Which wall do you remember first? We remember first of all medial wall. Medial wall, mnemonic USMLE, SMLE, sphenoid, maxilla, lacrimal, ethmoid. No issues in memorizing it. Over here for the sphenoid, we say it is a body. First you remember for the medial wall. This is the most important wall which is always very commonly asked. Then secondly, you remember for the floor. For the mnemonic floor, we said pajama, pajama lying on the floor. So pajama lying on the floor, so this is a mnemonic for floor, pajama, palatine, zygomatic, maxilla. These are the bones which are forming the floor, in which we say maxilla is having the main contribution. So medial wall, you first remember, this is the most important and frequently asked wall. Then the floor. Then coming to the roof, roof is frontal bone. You know this is a frontal plus sphenoid. So frontal bone plus sphenoid. Lateral side, you know which bone is this? Zygomatic. So the lateral wall, zygomatic plus sphenoid. So roof, frontal plus sphenoid. Lateral wall, zygomatic plus sphenoid. So these are the walls which are present in the orbit. Now coming to the in the orbit, the round foramen is optic canal and two oblique fissures, supia and the inferior orbital fissure, in which the superior orbital fissure, very important, divided into three compartments: medial, lateral, intermediate. And how we remembered over here? First we remembered lateral compartment. How we remembered? We just remembered the mnemonic. Will easen up your life. The lateral compartment mnemonic is L for lateral, so L for LFT. LFT super. Okay, LFT super. LFT, lacrimal frontal trochlear. These are the three nerves. Super LFT, or you say LFT is super. So super LFT, super is superior ophthalmic vein. Then for when you have remembered the lateral compartment, then you remember the intermediate. Intermediate, NOA. NOA is only the nerves nasociliary, oculomotor, abducent. So LFT super, we say is lateral compartment, NOA intermediate, and the medial compartment is inferior. We are not having any mnemonic for this. We say medial compartment inferior. So it gives passage to the inferior ophthalmic vein. It is giving passage to the inferior ophthalmic vein. So this is how we are memorizing: first lateral compartment, then intermediate, LFT super, NOA, and the medial is inferior. Now coming to the mandible. For the image based question, you should be able to identify the mandibular foramen. Then after that, we say what is passing through it. The structure passing through it is the inferior alveolar nerve and vessels. Inferior alveolar nerve, you will remember, going to the lower teeth. Mandible is present where? Where? At the location of the lower teeth. So inferior alveolar nerve and vessels. Alveolar, you know, it is for the teeth. So lower teeth and nerve and vessels. So inferior alveolar nerve and vessels, they are passing through the mandibular foramen. Now, as we come to the cervical vertebra, we said a foramen transversarium. There is an extra foramen which is present over here, foramen transversarium, and this is a characteristic feature of the cervical vertebra. So, for the cervical vertebra, we say what is the characteristic feature? The foramen transversarium. And for the foramen transversarium, we say what passes through it? The vertebral artery passes through the foramen transversarium of C1 to C6. Okay, it is C1 to C6, not C7, C6. C1 to C6 foramen transversarium gives passage to vertebral artery. Now, which vertebra is given the term as vertebra prominens? Yes, it is C7. And which is having the carotid tubercle? Very good, it is C6. So when you talk about the carotid tubercle, also known as Kasanac tubercle, where it is present in the C6, what is the importance? You can palpate or the pulsation of the common carotid artery over here. Common carotid artery pulsation over here. Coming to the C2 vertebra, that is the axis, we say it is having this upper projection known as dens or odontoid process. Dens or odontoid process. Pneumatic bones, you very well know, wherever the paranasal sinuses are there, frontal, maxilla, ethmoid, sphenoid, as well as the mastoid process. Now, as you come to scalp area, very important point, which is the dangerous layer of the scalp. The dangerous layer of the scalp is the fourth layer, loose connective tissue layer, which is also known as subaponeurotic layer. This is the dangerous layer of the scalp. Then very important points, all the points which are mentioned over here, they are important for us. Sensory supply of the face, the complete skin of the face supplied by trigeminal nerve, exception is skin over the angle of mandible. This area is supplied by great auricular nerve. Very important, very important point over here, the skin over angle of mandible. It is supplied by great auricular nerve. Now in the head and neck you are having a lot of exceptions. Okay, you have a lot of exceptions, but how we are memorizing over here, we are memorizing the main points. Wherever what point is important, I have highlighted that point, and you have to focus more on that point. Whenever you are memorizing the exceptions, you have to focus more on these points. Like over here, usually the question is asked of angle of mandible. They directly say that skin over the angle of mandible is supplied by great or the greater auricular nerve. Similarly, when we talk about the muscles, all muscles of the face supplied by facial nerve, and exception over here is muscles of mastication. And when you talk about the quotient, the muscle of mastication quotient, it comes more. So muscles of mastication supplied by mandibular nerve. Another exception, LPS, levator palpebrae superioris, supplied by oculomotor nerve. Now what are the four muscles of mastication? Masseter, temporalis, medial and the lateral pterygoid. These are the four muscles of mastication, which all four are supplied by mandibular nerve. All four supplied by mandibular nerve, in which we say that this is a temporalis muscle and this one is the masseter muscle. Temporalis in the temporal region, masseter over here. So very important, what are the four muscles of mastication? So all four are supplied by mandibular nerve. Now which is the dangerous area of the face? Now when you talk about the dangerous area of the face, what is the dangerous area of the face? We very well know this area, the nose, upper lip and the adjacent area, and it is drained into which vein over here? It is drained into the facial vein, and the facial vein is connected to which intracranial structure? It is the cavernous sinus. So facial vein, outside vein is connected to internal vein, which is cavernous sinus, and the dangerous area of the face is nose, upper lip and the adjacent area. The connection is from the facial vein directly, we can see that through these venous structures it is going to cavernous sinus. Alternate route is through the angular vein going to the superior-ophthalmic, and then it comes to the cavernous sinus. What is angular vein? The angular vein is the initial part of the facial vein. It is the initial part of the facial vein present near the medial aspect of the eye. So mainly we should be knowing what is the dangerous area of face, drains into facial, facial connected to cavernous sinus. And when you talk about the cavernous sinus, it is located on the either side of body of sphenoid. We have seen this image, it is present on the either side of body of sphenoid. And now what are the structures related to its lateral wall and what is on the medial side? Medial side we say the structures passing through cavernous sinus. Now for the lateral wall we say the mnemonic is MOTO, and it is maxillary, ophthalmic, trochlear, oculomotor. Now over here I am just putting it into your note that maxillary nerve, it is now under controversy that it is included or not. Okay, maxillary nerve is now under controversy. If we see the recent update, they are saying that the maxillary nerve is not towards the lateral side, it is slightly on the inferior aspect. So now we can say that if we are talking about the structures related to the lateral wall, the three answer, that is OTO, they are more specific answer for this. Maxillary nerve is under controversy. So you should be having this point in your mind when you are attempting the questions. This is a recent update. Okay, so ophthalmic, trochlear and oculomotor, these are specifically related to the lateral wall. Maxillary nerve under controversy. Then coming to the structures passing through cavernous sinus, the structures passing through cavernous sinus, abducent and the internal carotid. So all the nerves we have mentioned over here, and we say that through the cavernous sinus it is the abducent or internal carotid. When they ask a question, either they will ask for the lateral wall or they will ask about the structures passing through cavernous sinus, and we will answer it accordingly. Any infection reaching to the cavernous sinus from this dangerous area phase leads to cavernous sinus thrombosis, in which if the infection is there, we say all the 3, 4, 6 cranial nerves involved, ophthalmic nerve involved, venous congestion is there. So what will happen due to the 3, 4, 6 cranial nerve? All the extraocular muscle paralyzed. If you remember 3, 4, 6 involved, you automatically know it is all the extraocular muscles paralyzed. If the involvement of ophthalmic nerve, it supplies this area, so pain in the forehead. If the venous congestion is there, the venous blood is accumulated around the eyes, periorbital edema, and pushes the eyeball outward, exophthalmos. Now coming to the arterial system over here, common carotid divided into external and internal at what level? At the junction of C3 and C4. What is the vertebral level junction C3, C4? We say it lies at the level of upper border of thyroid cartilage. This point is important for you. One vertebral level, this one is important. Another vertebral level, we have already mentioned C6. So junction of C3, C4 is at the level of upper border of thyroid cartilage. Another landmark C6 we have mentioned earlier, it is along the lower border of cricoid cartilage. These two landmarks in the head and neck you should be knowing regarding the levels of the vertebral levels which are in correspondence to the cartilages. So at this level we are saying that it is dividing into external and internal. As the name suggests, external supplies all the structures over here, internal goes inside. So no branch for the internal carotid in the neck. Then as we talk about the branches of the external carotid, what is the mnemonic? The mnemonic we know, sulfopams, SU, superior thyroid, it is in the beginning, so we say it is a first branch. MNS, maxillary artery and the superficial temporal, they are in the last of this mnemonic, so we say these are the two terminal branches. So SU, superior thyroid, first branch, lingual artery, facial, occipital, posterior auricular, ascending pharyngeal, this is the smallest branch, maxillary and the superficial temporal, these are the terminal branches. All the branches according to the name, they are present at the same location. For the facial artery, we say two main branches giving of the superior labial artery as well as the tonsillar artery, right? And for the maxillary artery, it is giving the middle meningeal. The middle meningeal artery, we have earlier mentioned that this is very, very, very important for you. Middle meningeal artery, a branch of maxillary present here deep to the pterion and as well as passing through foramen spinosum. When you see the image over here, if you see this image, all the arteries are according to their location, according to the name they are present in the location. The most important over here is the facial artery, which you should be able to identify in the image. Any artery running obliquely in the face, so that is the facial artery, So if we say that this artery which is running obliquely in the face, only one artery you can see running obliquely in the face, and that is the facial artery, right? So this artery identification is very, very important. Then apart from this, if we see the other branches over here in the neck, lowermost side, we say this is a common carotid. Then at this level, it has divided into external and the internal. So we can say that this is external and this is the internal carotid. The external going up, internal, it goes inside the cranial cavity. It is giving external, it reaches in front of the ear where it divides into two terminal branches, and the two terminal branches are like this. The one going horizontally forwards, maxillary. The one which is going into the temporal region is the superficial temporal artery. Then apart from this, when we are talking about the branches, the branch going to the thyroid gland in the neck, superior thyroid. The branch going to the oral cavity, lingual artery. The branch going into the face, running obliquely in the face, facial artery. The branch going posteriorly, most posterior side, occipital artery. The branch going behind the ear, this is the posterior auricular artery. Then apart from this, we can say one more branch is there which arises near the beginning, and it goes on the medial aspect, and that is ascending pharyngeal artery. A very small branch which arises and goes on the medial aspect, that is the ascending pharyngeal artery. So these are the various branches over here, and Most important we have said is the facial artery. You should be able to identify the facial artery. For the lymphatic drainage, when we talk about the lymphatic drainage, Valdez ring, the components you should be knowing: pharyngeal, tubal, the pharyngeal tonsil, tubal tonsil, palatine tonsil and the lingual tonsil. The pharyngeal tonsil, it is also known as adenoids. It is also known as adenoids. The pharyngeal tonsil is also known as adenoids. So you should be basically knowing the components: pharyngeal tonsil, tubal tonsil, palatine and the lingual. What is the lymph node of tongue? The lymph node of tongue is jugulo-omohyoid. The lymph node of tonsil, jugulo-digastric. Tip of the tongue drains to the lymph node near to it, submental. Parotid lymph node drains over here, pre-auricular or the parotid lymph node. So lymph node of tongue, jugulo-omohyoid, and lymph node of tongue, jugulo-digastric. Then as we come for the parasympathetic ganglion, now this mnemonic has made our life so easy. The mnemonic is COPS 3977. The 4 ganglia related to these 4 cranial nerves, 3977. Now in the facial nerve, we said what are the 2 special branches. The facial nerve is having 2 special branches, 2 very important branches: greater petrosal nerve and the second is chorda tympani nerve. 2 special branches over here: greater petrosal, chorda tympani. These are the branches of facial nerve. We give petrosal to pterygopalatine. So I am giving P petrosal to P pterygopalatine. So we give petrosal nerve, the greater petrosal, to the pterygopalatine, and the other branch, chorda tympani, is for submandibular ganglia, right? And when you are talking about the petrosal nerve, you are having one greater and another is lesser petrosal nerve. So greater petrosal nerve is special. Greater, it is greater and it is special. So it is by a special nerve, 7th cranial nerve. It is coming from the 7th cranial nerve. The lesser petrosal nerve is coming from 9th, glossopharyngeal. So very important over here: greater petrosal, chorda tympani from facial nerve. Petrosal we give to the pterygopalatine, and another one, chorda tympani, is with the submandibular ganglia. What are the structures supplied by it? So we remember it perfectly: ciliary, ciliaris; submandibular gland; otic, parotid, and what is left? Pterygopalatine supplying the lacrimal gland. Okay, the pterygopalatine is supplying the lacrimal gland. Now when you are talking about these glands over here, now you can see the location over here, very important location, parotid gland. We know that what is the location? This is the location of the parotid. The gland which is present over here, this gland is the parotid gland. And we say what are the structures passing through it? One nerve, one artery, one vein. Most superficial, facial nerve. Then you have retromandibular vein. And then you have external carotid artery. These are the structures which are passing through parotid gland. The parotid duct opens where? The parotid duct, very important question over here. It opens where? It opens near upper second molar. You remember all the 3 words over here: upper second molar, upper second molar, upper second molar tooth. Then a clinical aspect associated over here: Fraze syndrome, which can occur after the surgery of the parotid gland. And whenever you talk about the Fraze syndrome, which nerve injury is there? You will always remember auriculotemporal nerve injury. The Fraze syndrome, it is an auriculotemporal nerve injury. The auriculotemporal nerve, it is a branch of the mandibular nerve. So whenever like Fraze syndrome is there, automatically you should think about auriculotemporal nerve. And what is this Fraze syndrome? When you're eating something, the redness, flushing, increased temperature on the lateral aspect of the cheek. It is not related with the texture of the food or the taste of the food. The food can be sweet, the food can be salty also, it can be spicy. Like any kind of food you eat, there is redness and sweating on the lateral aspect of the face. So that is a Fraze syndrome. For the rest of the 2 glands, we say they open in the floor of the oral cavity. Now coming to the temporomandibular gland joint. When you talk about the temporomandibular joint, for the ligaments, the ligament of the same name, temporomandibular ligament. So this is a temporomandibular joint. Over here, just lateral to it, lateral temporomandibular ligament. So the ligament of the same name, that is the main ligament. The other two ligaments are the accessory. The stylomandibular and the sphenomandibular, they are accessory. Now, very important over here, the action. What is the movement at the temporomandibular joint, or what is the action over the movement of the mandible? Very important over here. The first and the foremost, you will remember the depression of the mandible. And when you depress the mandible, you open the mouth. And which muscle? Lateral pterygoid. Depression of the mandible, lateral pterygoid. Depression of the mandible is lateral pterygoid. First of all, you will remember this. If the depression of mandible is lateral pterygoid, elevation by rest of three muscles. The rest of the three muscles, they are helping in the elevation. Automatically, you can remember this. Now, coming to the protraction. P for protraction, P for both pterygoids. Means medial as well as the lateral pterygoid. The protraction, P for protraction, P for pterygoid. Retraction, protraction is, what is protraction? You remember, protraction is protrusion. The mandible goes forward, and when you pull the mandible backward, then we say a strong muscle is required, so that is by temporalis, the bigger muscle temporalis. So first you remember for depression, lateral pterygoid. If you remember depression, lateral pterygoid, the rest of the three muscles, elevation. Then you remember protraction, P for protraction, P for pterygoids. And then we say retraction by a strong muscle, temporalis. Now coming to the neck area over here. When we talk about the neck area, what are the structures which are enclosed in the carotid sheath? Now, as the name carotid is there, so of course the carotid artery will be there. Of course, the main vein, internal jugular vein will be there. The main artery, the main vein, carotid artery and the internal jugular vein. In the carotid artery, we say common carotid and internal. The internal remains inside, external goes outside. So it goes outside the carotid sheath. So internal, it remains on the inner side. So common carotid and internal. Then you have internal jugular vein. What is the nerve over here? That is very important for you. Which nerve is present inside the carotid sheath? That is the vagus nerve. The vagus nerve is inside the carotid sheath. Then for the ansa cervicalis, you will remember SOS. Ansa cervicalis, a nerve loop which is present in the neck, supplies SOS. S is sternohyoid, omohyoid, both the belly, superior and the inferior. And another S is sternothyroid. So SOS, ansa cervicalis. SOS, ansa cervicalis. So SOS is a mnemonic for ansa cervicalis, sternohyoid, omohyoid and the sternothyroid. Now coming to the thyroid gland. Now as we talk about the thyroid gland over here, for the lobes we say the extent is C5 to T1 and for the isthmus it is C7. Okay, C5 to T1 lobe and the isthmus is C7, and we know that it is supplied by superior and the inferior thyroid artery, but over here you should be knowing thyroidea ema artery, which can be present sometimes. Thyroidea ema artery, the word thyroid is already coming over here, so this is for the thyroid, thyroidea ema artery. Whenever it is present, it is taking origin directly from arch of aorta. It is taking directly origin from arch of aorta. So this is for the thyroid gland. Now when you come to the extraocular muscle, in the extraocular muscle we have already mentioned that annulus of Zinn is a common origin for all the recti muscles, and according to the name the muscles are present: superior, inferior, medial and the lateral. Above the superior rectus, the levator palpebrae superioris is going anteriorly towards the upper eyelid. Then as you see the superior oblique, this is a muscle showing the superior oblique which is going forward and taking a turn and coming back. Inferior oblique is present on the lowermost aspect from the floor of the orbit. So that is why we say that all the extraocular muscles, they are taking origin near the apex of the orbit except one muscle which is inferior oblique. You can see the inferior oblique over here is taking origin from the floor of the orbit. Now when you are talking about the extraocular muscle, you remember two mnemonics over here. What are the two mnemonics? You very well know LR6SO4. And another mnemonic is SYNRAD. The SYNRAD mnemonic is for action and LR6SO4 is a mnemonic for nerve supply. LR6 is lateral rectus 6, abducens nerve. It is supplied by that. SO4 is superior oblique 4, supplied by trochlear nerve. The rest of the muscles are supplied by oculomotor. Also ciliaris and sphincter pupillae, they are also supplied by oculomotor nerve. So all the rest of the muscles by oculomotor nerve. Now when you are talking about the action, medial rectus present on the medial side, it is on the medial side, it pulls the eyeball towards itself, so adduction. Lateral rectus present on the lateral side, so it pulls the eyeball towards itself, so we say it pulls the eyeballs outwards, so that is abduction. So medial rectus adduction, lateral rectus abduction, levator palpebrae superioris because attached to the upper eyelid, elevation of upper eyelid. These three muscles, they do one action each, and the rest of the muscles we have mentioned over here, they are doing three action each. And for that we remember by this mnemonic SINRAD. First of all, we say superior rectus, according to the name, helps in elevation of the eyeball. Inferior rectus, according to the name, it helps in the depression of the eyeball. But what about the obliques? We said obliques are oblique. They are doing some opposite thing. They are doing some different thing. And the superior oblique, it helps in depression of the eyeball. Very, very important point. Superior oblique is helping in depression, and opposite to that, inferior oblique helps in the elevation. So you always remember superior oblique is helping in the depression of eyeball. Then apart from this, we apply this mnemonic over here now, SIN-RAD. SIN is superior's intort, RAD is recti adduct. And if you put this mnemonic over here, for example, in the superior rectus, if you put, so superior's intort, so superior rectus is helping in the intorsion, recti adduct, so it is helping in the adduction. And in this way, we can add the all other actions over here. If the superior rectus is doing intorsion, the another muscle is doing the extorsion. Very important over here, superior rectus, what is a combination of three movements? Elevation, intorsion, adduction. And we remember how we remember with the help of this mnemonic. You are going to remember the actions with the help of this mnemonic. Now coming to the oculomotor nerve lesion. When there is effect to the eyeball, the muscles of the eyeball, the oculomotor nerve lesion is there. Very, very important key points over here is fixed and dilated pupil. Fixed pupil means not reacting to the light. So fixed and dilated pupil. Another point very important for you is down and out position of the eyeball. If these 2 points are mentioned, you know that this is for oculomotor nerve lesion. So these 2 points are for oculomotor nerve lesion, fixed dilated pupil, because there's intraocular muscles are involved, ciliaris and sphincter pupillae. Down and out position because the lateral rectus and superior oblique, there is nobody to stop them, so they pull the eyeball towards themselves. As well as ptosis is there because levator palpebrae superioris is gone. So the main 2 symptoms over here is, always remember, fixed and dilated pupil and down and out position of the eyeball. This is for oculomotor nerve. Now coming to the tongue, we say that very, very important in the tongue is the sensory supply. Very, very important, sensory supply. We know that the tongue is supplied by which nerve? It is supplied by the hypoglossal nerve. The hypoglossal nerve, it is the one which is supplying the tongue, muscles of the tongue. And when you talk about the sensory supply, very, very important, the different sensory supply for anterior 2/3, posterior 1/3 and the posterior most. In the anterior 2/3 supplied by 2 nerves, posterior 1/3 and the posterior most by one nerve. What are the 2 nerves on the anterior side? 2 nerves on the anterior side is lingual nerve, chorda tympani. Okay, lingual nerve, chorda tympani. We say which is more special. We always say chorda tympani is a special nerve because it is a special branch of 7. Chorda tympani is a special nerve because it is special. We say it is carrying the special taste sensation. Okay, it is carrying the special taste sensation, and the lingual nerve is carrying the general sensation. This is for anterior 2/3. For the posterior 1/3 as well as for circumvallate papilla, now we say both general and the taste sensation by glossopharyngeal nerve, and the posterior most part, again the both sensations they are carried by the vagus nerve. Okay, again both sensations are carried by the vagus nerve. Now the genioglossus muscle over here, this is very, very important point over here. We say genioglossus muscle. What is the action of genioglossus muscle? It is helping in the protrusion of the tongue, and due to this it is known as safety muscle of the tongue. If hypoglossal nerve injury is there, what will be the when you ask the patient to take out the tongue is deviated to which side? The tongue is deviated to the same or the opposite? We say that the tongue is deviated to the same side of lesion. It is deviated to same. It is deviated to the same side of the lesion. So in the hypoglossal nerve injury, the tongue is deviated where? To the same side of the lesion. This is a very, very important point, that which side? Same side. Now coming to the pharynx, in the pharynx you should be knowing that this exception is very, very important, that stylopharyngeus is supplied by which nerve? The stylopharyngeus, it is supplied by glossopharyngeal nerve. This is a very important exception over here. So when we are talking about the pharynx, we say that two muscles are important. One is this stylopharyngeus supplied by glossopharyngeal nerve. Another is the inferior constrictor, in which you have Killian's dehiscence. And the Killian's dehiscence specifically is present between which two parts? It is between the thyropharyngeus and the cricopharyngeus. Now in the nasopharynx, the eustachian tube is opening in the nasopharynx. The eustachian tube opening is in the nasopharynx. Now as you come to the larynx we say it is extending from C3 to C6, and we very well know which are the paired and the unpaired cartilages. We say unpaired is thyroid, cricoid and the epiglottis, and the paired ones is the arytenoid, corniculate and the cuneiform. When you see the image, you can very well say that this is the thyroid cartilage and this is the cricoid cartilage over here. These two you can easily identify from the anterior side, and posterior side you are able to identify this leaf shaped cartilage, epiglottis, and another is this triangular cartilage which is the arytenoid. So these cartilages you should be knowing. Then as we talk about the other points, we say two muscles are important for me. What are the two muscles important? One is the cricothyroid, another is the posterior cricoarytenoid. Cricothyroid nerve supply. It is supplied by external laryngeal nerve. The cricothyroid, it is supplied by external laryngeal nerve. And when you talk about the posterior cricoarytenoid, its action is very important. It is helping in the abduction of the vocal cord. So posterior cricoarytenoid, it is helping in the abduction of the vocal cord. So these two muscles are very important in the larynx, and you should be memorizing these two muscles. Cricothyroid, external laryngeal nerve; posterior cricoarytenoid, abduction of the vocal cord. Now coming to the Little's area, we know that the Little's area is present in the nasal septum, and very, very important for you that which are the arteries participating in the Little's area. There is an anastomosis of 4 arteries, which is known as Kisselbeck's plexus. Present which arteries? We say which arteries over here? Anterior ethmoidal, then we have greater palatine artery, sphenopalatine artery, superior labial artery. These are the 4 arteries which are participating in this anastomosis, and the Little's area is a very vascular area in which quadrant? Anterior inferior quadrant of nasal septum. So these are the 4 arteries which are participating in the anastomosis. Now another point over here that you should be knowing, in the meatus, what sinuses are opening over here? Sphenoethmoidal. It is starting with the word spheno. So we say spheno gives drainage to the spheno, that is sphenoid sinus. Sphenoethmoidal recess is giving drainage to the sphenoid sinus. Then another you have superior meatus, which is giving drainage to the, over here the sinus which is draining is the posterior ethmoidal. Middle meatus, the rest of the ear sinuses, that is we say the frontal, maxillary and rest of ethmoidal, that is the anterior and the middle ethmoidal ear sinuses. And when you talk about the inferior meatus, the inferior meatus is giving opening to nasolacrimal duct. The nasolacrimal duct is opening into the inferior meatus. Now over here, the superior sphenoethmoidal, the middle meatus and inferior meatus, they are more important. That what structures are opening over here. Now as we come to the facial nerve. Now for the facial nerve, we have said 2 branches most important. What are the 2 special branches? We said greater petrosal, chorda tympani. Greater petrosal. Which petrosal nerve? Greater petrosal, chorda tympani. Always remember these 2 branches are the special main branches of facial nerve. And then we say the greater petrosal, nerve 2 stapedius, and the chorda tympani. These are the three nerves which are given off in the middle ear. The greater petrosal nerve is the first branch. It is the first branch. Now, for the facial nerve, we usually talk about the lesions, upper and the lower motor neuron lesion. Whenever you are talking about the upper and the lower motor neuron lesion, we say what is the keyword over here to differentiate it. The keyword over here is the forehead muscle. If the forehead muscle is involved, if it is paralyzed, then it is the lower motor neuron. If it is paired and not involved, then we say upper motor neuron. So with the help of forehead muscle, you can differentiate between upper and the lower motor neuron. If the forehead muscle is paralyzed, lower motor neuron, and what is the symptom? The symptom is loss of transverse wrinkles on the forehead, like this. When we are raising the eyebrows, the transverse wrinkles are formed. These transverse wrinkles are lost. So loss of transverse wrinkles on the forehead on affected side, of course, on the same side of the lesion. So this is a key point over here. Whenever you are solving any clinical question, one point, forehead muscles you should be very well knowing. Forehead muscle paralyzed, lower motor neuron or the Bell's palsy, and there is loss of transverse wrinkles on the forehead. Now when you talk about the upper motor neuron, for the upper motor neuron lesion, we say if the lesion is on this side, the effect is on the opposite side. So we say contralateral lower half of the face is involved, forehead not involved, so we say forehead spared. Okay, in the lower motor neuron, we say same side, ipsilateral half of the face is paralyzed, including the forehead, This is the effect for upper and the lower motor neuron. Then for the lower motor neuron, it is also known as Bell's palsy, and we say one symptom is main, that is the loss of transverse wrinkles on the forehead. Another main symptom is the angle of the mouth. This is the angle of the mouth which is tilted down. The angle of the mouth is tilted down on the same side of the lesion. Okay, this is also on the same side of the lesion. It is on the same side of the lesion. These two symptoms are most important over here. The angle of the mouth tilted down on the same side of the lesion and the loss of transverse wrinkles on the forehead. The rest of the points are basically used to make a story in the clinical questions. But these 2 points are the most important points for the facial nerve palsy, the Bell's palsy. Now coming to this image is very important for you for an image based question. And the important, earlier the landmark genioglossus has been asked, and this projection over here, this is known as epiglottis. This has been asked earlier. Then apart from this, another important landmarks over here is this sinus is sphenoid sinus. Above this, whatever U-shaped depression is there, that is the sella turcica, right? Then as you see these vertebrae over here, this small section is the C1 and this bigger section, the bigger section is C2. The bigger section is C2. These are the most important landmarks over here. Then if you come on the anterior side, you know that a sinus which is present over here is a frontal sinus. This is a frontal sinus. Then this partition between the nasal and the oral cavity, this is the hard palate, and behind the hard palate, whatever structure is hanging over here, this is the soft palate. So hard palate and behind it soft palate. Then as you come into the nasopharynx, in the nasopharynx, whatever opening is there, this opening which you can see in the nasopharynx, this is the eustachian tube opening in the nasopharynx. Then a section which you see over here, I will just focus it. A small section which you see over here, this is a section of hyoid bone. Then you are having this area which is the larynx. Okay, this is the area which is the larynx. So these are the important landmarks which you all should be knowing in this image. Okay, now coming to the other points over here for the cranial nerves, we say the pure sensory 1, 2, 8, pure motor 3, 4, 6, 11, 12. And the mixed cranial nerves are the rest of the cranial nerves 5, 7, 9, 10. Now, very, very important is which cranial nerves carry parasympathetic fibers. It is 3, 7, 9, 10. 3, 7, 9, 10. This is the most important point for cranial nerves. Parasympathetic fibers carried by 3, 7, 9, 10. 3, 7, 9, 10. 3, 7, 9, 10 parasympathetic fibers are carried by these cranial nerves. Now, which cranial nerve is arising from dorsal aspect of the brainstem? This is the trochlear nerve. And which cranial nerve is involved in increased intracranial pressure? That is the abducent nerve. That is abducent nerve. Then apart from this, the nerve undergoing internal decussation, that is the trochlear nerve. These are the most important points over here for the nerves. Parasympathetic fibers 3, 7, 9, 10. 3, 7, 9, 10. Then apart from this, when we are talking about the named nerves, we say that these two nerves are main. The Arnold Edelman auricular branch of vagus, AAA. Then Jacobson nerve is tympanic branch of glossopharyngeal nerve. Then you are having the nucleus. It is a common nucleus for these three nerves, and the common nucleus is given the term as nucleus ambiguous. So nucleus ambiguous is a nucleus for which three cranial nerves, 9, 10, 11. And the nucleus tractor solitarius is for three cranial nerves, 7, 9, 10. Then coming to the three nerves which arise at pontomedullary junction, it is 6, 7 and 8. So it is 6, 7, 8 which arise at pontomedullary junction. Then coming to these last points over here, we say the head is at what vertebral level? It is the level of C3. Lesser petrosal nerve we mentioned earlier, it is a branch of glossopharyngeal nerve. Palatine tonsil, it is supplied by glossopharyngeal nerve. And this point also we have mentioned earlier, all extraocular muscles attached to the apex of orbit except inferior oblique, except the inferior oblique. So over here we have completed this revision of the head and neck portion, and we will quickly take a break. Okay, we will take a break for 15 minutes, and then after that we will resume the class. So what is the time at present? It is 3:36, or we can say 3:40. So we can resume the class at around 3:55. Okay, around 3:55 p.m. we will resume the class. So we are just taking a short break over here, and then after that we will continue the revision. Okay, so we are back from the break, and now after the break we will be starting with the neuroanatomy portion. Okay, we will be revising the neuroanatomy portion. Now, in the neuroanatomy portion, these two images are very, very important for you, and very important, we very well know that this sagittal section, this sagittal section is very, very important for you. Now, when you see the lateral view, you very well know whatever sulcus is present on the lateral side. This is a lateral sulcus, also known as Sylvian fissure. Okay, lateral sulcus, Sylvian fissure. This is the most important sulcus which you can see in all the images, which is from the lateral side. Another sulcus which is present over here is the central, also known as Rolando sulcus. Now, when you come to the sagittal section, now in the sagittal section, first of all, you very well know that the C-shaped structure, this C-shaped structure is the corpus callosum. Whatever C-shaped structure is there, so this C-shaped structure, this is a corpus callosum. Then in the brainstem, we remember by what we have said. Whenever you're talking about the brainstem, remember like midbrain, pons, medulla. Remember in this order only: midbrain, pons, medulla, midbrain, pons, medulla. So whenever you see this image, whatever expanded portion is there, that expanded portion is a pons. Above it, midbrain; below it, medulla. Then behind it, we know is a cerebellum, and whatever space is between the pons and the cerebellum, between what? Between pons and cerebellum, that space or that triangular area is known as fourth ventricle. That is known as fourth ventricle. So this is the location of the fourth ventricle. This is another important landmark over here. Pons has been asked recently. Another important landmark is the fourth ventricle. Then what are the other landmarks? When you see the C-shaped corpus callosum, whatever projection is coming from this C-shaped structure, this is, we have said, fornix. Okay, this is the fornix. Then as we come to midbrain, when you talk about the midbrain, we have already identified that this is the midbrain. As you go anterior to the midbrain, a structure which is hanging from above, it looks like as a purse is hanging from above, that is the pituitary gland. So I will just zoom it over here. This is the midbrain, and a structure which is hanging in front of it, this structure is the pituitary gland. And in between the two, we say over here, I am showing a small round structure. So you can say in between the midbrain and the pituitary. Again, let us see over here. This is the midbrain and this is the pituitary gland. In between that, you are having a rounded structure, and now that rounded structure is known as mammillary body. Okay, this is known as the mammillary body. MB. We say this is mammillary body. This is a mammillary body. So we say that this round structure which is between the midbrain and the pituitary, this is a mammillary body. These are the other landmarks which you should be knowing over here. Then apart from this, whatever area is present below the corpus callosum, that area is the thalamus. So this area is the thalamus which is just below the corpus callosum. As you go more below, then you are having hypothalamus. The more important over here we know is thalamus. So thalamus is the area which is just below the corpus callosum. So this sagittal section is very, very important for you. You should be knowing this image, as well as if the radiographic image is given, exactly the same structures will be seen over there also, and you should be able to identify it. Fine. Now, when coming to the other points, when we talk about the spinal cord, very, very important, where does the spinal cord end? The spinal cord ends at L1, lower border of L1 in adults, and upper border of L3 in newborns. Newborns, or we say till 1 year of age. So that is in the infants. And when you talk about the other structures, the subarachnoid space, it ends where? At the level of S2, lower border. So in the adults, we say spinal cord also at lower border and the subarachnoid space also at upper border. When we talk about the adults, we say spinal cord also lower border and the subarachnoid space also lower border. The upper border we have mentioned in the newborns. Okay, this is just for memorizing. Then apart from this, the pia mater it extends below as phylum terminal and it is extending till the coccyx, The spinal cord and the subarachnoid space, very important over here. Then coming to the corpus callosum, these are the 4 parts of corpus callosum starting from the anterior to the posterior side. So whenever you see a projection, some projection going down, that is the anterior side. And this projection is rostrum, then a turn is there, genu, body, and this posteriorly expanded portion is the splenium. Other components of corpus callosum includes forceps minor, forceps major and the tapetum. These are the other components of the corpus callosum. Now, as you come to the white matter fibers, we say association, commisural, projection. As the name suggests, association in the same hemisphere. Commisural are the connecting, they connect the right and the left hemisphere. Projection, they are projecting from cerebrum to the other parts of the brain. Okay, to the other parts of the brain. When you talk about the association, we say when we are memorizing the association, we say all the fasciculus, they are present in the association. Or we say FUS. It is like फंसा हुआ है. Association मतलब फंसा हुआ है एक ही cerebrum में. So we say all the fasciculus, they are present. They are the examples of association. Then another example is cingulum. We can remember by this cingulum word single. Okay, cingulum. So single. So that is why in the single same hemisphere. Cingulum is also in the same hemisphere. Just give me a minute over here. So the association fibers, we say fasciculus, which are in the same hemisphere, and the cingulum. Then connect the commisural. Commisural will be having the word commisural everywhere, and corpus callosum. Very important example, largest commisural fiber, CCC, corpus callosum commisural. Projection, it includes internal capsule, corona radiata, tracts, and the fornix. And when we are talking about these internal capsule, corona radiata, we say that these fibers which are radiating in different directions, this is the corona radiata. Then as it comes between this nucleus, we say this is the internal capsule, and as it is projecting down, then we say it is the tracts. This is the tracts. So these are the projection fibers which are going from cerebrum to the other parts of the brain. An internal capsule is a component which is between the nucleus, sandwiched between the nucleus, and this is a bundle of fibers over here. Corona radiata, which are having the appearance as if they are radiating. So all these are the examples of the projection fibers. Now as we talk about the functional areas, for the functional areas we say in front of the central sulcus motor, behind it sensory, towards the occipital region visual area. The visual area is in the occipital region. Then below the lateral sulcus auditory, and then we are having the Wernicke's speech area. And in the lower part of the frontal lobe, you can see Broca's speech area. These are the various speech area, these are the various functional areas over here, and very important, their area number. The area number is most important. Motor area 4, sensory area 312, it is 312. Then for the paracentral lobule, we say it represents specifically the perineum and the lower limb. Visual area 17, 18, 19. Auditory area 41, 42. Then we say the speech area are the most important. The sensory speech area, which is the Wernicke's, it is 22. Okay, mainly they ask about 22. So it is a sensory or the Wernicke's 22, and the Broca's or the motor is double of it, 44, 45. Okay, 44, 22, and this is 44, 45. And arcuate fasciculus is the one which connects the Broca's and the Wernicke's speech area. Okay, arcuate fasciculus. Now whenever you are talking about the blood supply of the cerebrum, we say that on the lateral aspect, that is the main, and on the lateral aspect, the main artery supplying the lateral surface is middle cerebral artery. It is a middle cerebral artery, and for the visual area we say it is specifically supplied by posterior cerebral. So when you see the lateral surface over here, this whole area is supplied by middle cerebral, posterior side is supplied by posterior cerebral, and anterior cerebral is supplying this small strip on the upper side. So this is the arterial supply for the cerebrum. Now when you come to this image over here, first of all we see this image, and this is a very important image. Everybody should be able to answer this question. No error should be there. When you see this image, what you will see from the outer side, whatever triangular nucleus is there, that is the lentiform. As you come on the inner side, you see oval shaped nucleus, big oval shaped nucleus, thalamus, small oval shaped nucleus, caudate nucleus. Exactly the same orientation over here, and the bundle which is present between these three nucleus, this is an internal capsule. This is the internal capsule. Then between the two thalamus, whatever space in the midline you see, this space is third ventricle. So the third ventricle we say is between the two thalamus. And when you talk about the lateral ventricle, a triangular section which you can see over here near to the caudate nucleus, that is a specific location for the lateral ventricle. That is a lateral ventricle. Then the connecting fibers shown over here, this is a corpus callosum, and from the lateral aspect, whatever sulcus is dipping over here, that is the lateral sulcus, and the area of the cerebrum around it is the insula. All these are the important landmarks over here. And if I come back to this image over here, we can very well see this is a location of third ventricle, this is a location of lateral ventricle, then this is the lateral sulcus which is coming from the lateral side, and whatever area is around it, that is the insula. Then apart from this, what are the other landmarks which you should be knowing? Towards the posterior aspect of the image, this is the posterior aspect of the image, you see some triangular section which is the superior sagittal sinus. Okay, this is the superior sagittal sinus. Then just in front of this you see some round area which is the straight sinus. The straight sinus has been asked in the June exam. So if this question is repeated, you should be able to answer it. So the transverse section or the coronal section, they will be having the same appearance, and this section is superior sagittal sinus and this one is the straight sinus. Now coming to the components of diencephalon, the most important component is the thalamus and the hypothalamus. Thalamus very important. Lateral geniculate body, it is for vision, optic radiation, and when you talk about the medial geniculate body, it is for the auditory radiation. Then we have one more component over here, pineal body, but the main component is thalamus. Always remember, thalamus, hypothalamus are for diencephalon. And when you talk about the basal ganglia, these three nucleus are the most important: caudate, putamen and globus pallidus. And in this also, globus pallidus, putamen together, lentiform nucleus. So these two together are known as lentiform, and all the nucleus together are known as corpus striatum. So upper three nucleus are the most important nucleus for the basal ganglia. This is for the basal ganglia. Then in the internal capsule, we know that this green colored area, V-shaped area, is internal capsule. On the lateral side, lentiform nucleus. On the medial side, caudate and the thalamus. In the lentiform triangular nucleus, we say inner aspect is globus pallidus, and on the outer side, this area is the putamen. So together, globus pallidus, putamen, they form the lentiform nucleus. Now when you talk about the brainstem, we say that we are having landmarks for medulla, for pons and for the midbrain. When you see the anterior aspect of the brainstem, you can see prominences in the medulla over here. Near the midline, whatever prominence is present, that is the pyramid, right? Deep to it, pyramidal tract, or we say corticospinal tract. So pyramid is the elevation in the middle. Just lateral to it, you have olive. What is deep to the olive? Inferior olivary nucleus. So when you talk about the medulla, we say two landmarks over here important for you: pyramids and then the olive. On the posterior side, when you see, you have a landmark facial colliculus which is at the level of pons, and at the level of midbrain, four prominences together: upper two superior colliculus, lower two inferior colliculus. Now for the facial colliculus, it is specifically present at the pons. Deep to it, you are having facial nerve and abducent nucleus. The answer will be according to the options. First structure deep to it is the facial nerve, and as we go more deeper, you have the abducent nucleus. So these are the structures deep to it. Now coming to the cerebellum, in the cerebellum we say that each hemisphere is divided into 3 lobes, anterior, posterior, and the third lobe is which lobe? Flocculonodular. The third lobe is flocculonodular. So the flocculonodular word is for the cerebellum. When you see the flocculonodular word over here, this is for cerebellum. And now coming to one more word, Purkinje cell. For the Purkinje cell, we say that this is the characteristic cell of cerebellum. It is a characteristic cell of the cerebellum. So Purkinje cell is for the cerebellum. Always remember, Purkinje cell is for the cerebellum. And now coming to the deep cerebellar nuclei. What is the mnemonic? Deep cerebellar nuclei, D, E, F, G. Everybody knows A, B, C, D. So D, E, F, G. Dentate, emboliform, fastigial, globose. Okay. These are the 4 nucleus. Even if you remember the mnemonic, you are able to answer the question. So D, E, F, G. In the cerebellum, we say the final output or the efferents are formed by deep cerebellar nuclei. Now coming to the ventricles, very important is its location. Now when you talk about the location over here, we very well know that the lateral ventricles, right and the left, they are present in the cerebral hemisphere. Okay, they are present in the cerebral hemisphere. Then apart from this, the third ventricle we said just now between the 2 thalamus. And thalamus is a part of diencephalon. So between thalamus or between diencephalon. Fourth ventricle we mentioned earlier between the pons and the cerebellum. Between the pons and cerebellum. Now over here, this is a flow chart which is showing the flow of the cerebrospinal fluid. The formation, it starts from the choroid plexus of lateral ventricle. Now over here you should be knowing all these connections. The connections which are between the various areas. We say the first connection is interventricular foramen of Monro, which connects the lateral ventricle to the third. And the third ventricle is connected to the fourth ventricle by cerebral aqueduct of Sylvius. And from here, fourth ventricle, the CSF goes to the subarachnoid space via the foramen of Magenti and foramen of Lashka. Then the absorption occurs in the subarachnoid space, specifically at arachnoid villi or granulations, and the CSF is returned to the superior sagittal sinus. This is a complete flow which you should be knowing. Now coming to the arteries of the brain. Now whenever we are memorizing the arteries of the brain, how we remembered? Anterior side of the brain, internal carotid, posterior side of the brain, vertebral artery and the basilar artery. Okay, internal carotid over here, vertebral and basilar over here. The vertebral artery, 2 vertebral arteries, they unite to form basilar. The 2 vertebral arteries unite to form basilar. Now first of all, what are the most important arteries over here, which can be asked as one-liners? We first of all remember posterior inferior cerebellar artery, which is the pica. We first of all remember this, posterior inferior cerebellar artery. The posterior inferior cerebellar artery is a branch of the vertebral. It is a branch of the vertebral. So because the vertebral is present over here, it is giving supply to the cerebellum. Also it is giving supply to the spinal cord. So anterior spinal artery as well as the posterior spinal artery, they are given off by the vertebral. The main artery over here is pica, which can be asked as a one-liner. If the pica is coming from vertebral, the ica is coming from basilar. It is coming from basilar. And when we talk about the internal carotid, over here we say the main artery is anterior choroidal. So pica, vertebral, ica, basilar, anterior choroidal, internal carotid. Pica, vertebral, ica, basilar, anterior choroidal, coming from internal carotid. Then apart from this, we say this is a cerebellar artery. It is also giving off, vertebral is also giving off the anterior and the posterior spinal artery, in which we say 1 anterior and the 2 posterior spinal artery. And the anterior spinal artery is supplying only the anterior 2/3. It is supplying the anterior 2/3, the rest of the portion posterior 1/3 by posterior spinal artery. Then the basilar artery, when we are talking about this, we say ica is given off by this. Another important branch, just for your knowledge, posterior cerebral, because it is on the posterior side, so it is supplying the posterior aspect of cerebrum. And the internal carotid, because it is on the anterior side, so it is supplying anterior and the middle part of the cerebrum, anterior and the middle cerebral artery. For the circle of Willis, we say it is between the branches of internal carotid and the basilar, and we say two anteriors, two posteriors. Two anteriors, two posteriors, they form the circle of Willis. What are the anterior and the posterior? Anterior cerebral, anterior communicating, posterior cerebral, posterior communicating. So two anteriors, two posteriors, they are helping in the formation of circle of Willis. No participation of middle cerebral artery. And when you talk about the image based question over here, if you see this image, first of all, you should be able to tell that these two are the vertebral artery. They combine to form the basilar. Now in the vertebral artery, whatever branch is coming from the lateral side, this is the pica, which is the most important branch over here to identify. And this branch which is on the in the center over here, this is the anterior spinal artery. These two branches are very, very important for image based question. Okay, this image is important for you, this image, and these two arteries are the most important. Then as you come to the basilar artery, for the basilar artery we say that one branch on the lowermost side, another branch on the highermost side. The branch on the lowermost side is ICA and the branch on the highermost side is posterior cerebral artery. These two arteries you should be knowing. When you come to the internal carotid, for the internal carotid we say two branches going anteriorly. This is the anterior cerebral artery. Okay, this is the anterior cerebral artery. Then artery which is going on the posterior side, this is the posterior communicating artery. This is the posterior communicating artery. So we say on the anterior side, anterior cerebral, and between the anterior cerebral, whatever communication is there, that is formed by anterior communicating artery. So two anterior cerebral going on anterior side, connected by anterior communicating. Then posteriorly we said posterior communicating coming behind, and you can see it is anastomosing with this artery. Which artery is this? This is the posterior cerebral artery over here. It is anastomosing with the posterior cerebral artery, and thereby we say that it is forming this circle of Willis. It is forming the circle of Willis. So these are the arteries which you should be knowing in this image. And when you see this image, of course, while you see this image, you know that in this image, the upper portion of the image, this is for internal carotid, the middle portion is for basilar artery, and the lower portion is for the vertebral artery. So whenever you see this image, you should be able to tell. You should be able to think that what are the portions where these main arteries are present. Now, very important over here, we have talked about the syndromes. The lateral medullary, we say that it is also known as Wallenberg syndrome, and this is due to the occlusion of pica. It is due to the occlusion of the pica, posterior inferior cerebellar artery, and the medial medullary syndrome, it is due to the occlusion of anterior spinal artery. Now over here, I got a lot of doubts from the students that if regarding the vertebral artery more better answer than this pica or on the anterior spinal artery as mentioned by in the medicine. So like for that, if both the options are given, it is very less chances that both options will be given. Usually they give the specific answers, pica or the anterior spinal artery. If 1%, we say 1% or 0.5%, if both are given in the options, then you can go for vertebral artery. Okay, you go for vertebral artery first, and then you can go for like if only the specific is there, then of course you know the specific artery very well. If both are mentioned, then you go for vertebral, but usually the both are not given. Okay, very less chances, very less. They always give the specific branches, so no confusion in that. Lateral medullary you should be knowing is pica, and the medial medullary is the anterior spinal artery. Whenever you are talking about the lateral medullary, also known as Wallenberg, a very important expected question. We have just memorized. How we memorized? As if we have taken a lot of alcohol. So intoxicated position, or like when you have taken a lot of alcohol, so nausea, vomiting is there, dizziness is there, giddiness, unable to walk, unable to talk, unable to eat, unable to do all these things, and as well as the taste is also lost. Okay, everything, multiple symptoms are there. So you just see that whatever that intoxicated kind of stage is there, in that way all the multiple symptoms are there, plus contralateral loss of pain and temperature. Now when you talk about medial medullary, over here you just remember, usually they ask about lateral medullary, but for the medial medullary, if it is 0.5%, you should be knowing that what is actually happening over here. There is an involvement of cranial nerve 12, and this is of course ipsilateral. So same side cranial nerve 12 involvement is there, and along with other symptoms. So if any question is mentioning the various symptoms, neurological symptom, along with 12th cranial nerve involved. So 12th cranial nerve is the keyword over here. If it is involved, then we say it is medial medullary syndrome. Then in the spinal cord, the lumbar puncture is the most important over here, and this mnemonic is very important. The mnemonic is silly. Okay, so don't do any silly mistake in this. Lumbar puncture, silly. What is the 3 ligaments pierced? What is the order? SIL. Supraspinous, interspinous ligamentum flavum. Okay, these are the structures. So whenever we are talking about the structures pierced, we know skin, fascia, muscle, then SIL, then dura mater and the arachnoid. For the epidural space, to reach to the epidural space, you pierce only upper 5 structures. And for the epidural space, we say the last structure pierced is the ligamentum flavum. So don't do any silly mistake over here. SIL, supraspinous, interspinous, ligamentum flavum. Now coming to this image over here, in this image, you should be knowing the location of the dorsal column. This is a one you can say tract which can be asked as a image based question. If this image is given, you see the this gray matter, the broader portion is on the anterior side, the narrow portion is on the posterior side, and on the posterior side this whole tract which is occupying the whole posterior side, that is a dorsal column. Okay, that is a dorsal column. The lateral horn is present only at specific location from T1 to L2, only T1 to L2. Now whenever we are talking about the 3 tracts, ascending tracts, sensations carried by them very, very important. Okay, sensations carried by them very important. So dorsal column, spinothalamic tract, sensation carried. We will be talking about 3 tracts: dorsal column, spinothalamic and corticospinal. The dorsal column and the corticospinal crossing of fibers at the level of medulla, and spinothalamic crossing level is spinal cord. Then the sensations carried by dorsal column, these 3 sensations are the most important: fine touch, vibration, conscious proprioception, also known as joint sense. Very, very important. The sensations carried by this, you should be knowing very well. The dorsal column, these 2 sensations, when you compare it with anterior spinothalamic, it is crude touch and pressure. And when you talk about the lateral spinothalamic tract, we say pain and temperature. So first of all, you will remember the sensations carried by dorsal column and the spinothalamic. Then you remember the crossing of the fibers only in the spinothalamic at the level of spinal cord, and the rest of the 2 at the level of medulla. Then apart from this, the dorsal column is having 2 parts: gracilis, fasciculus, gracilis, fasciculus cuneatus. For that we remembered by the mnemonic gracilis for ground. So lower part of the body, gracilis fibers, and upper part of the body, cuneatus. And therefore we are having this specific nucleus associated with dorsal column, gracile and cuneate. Gracile nucleus and the cuneate nucleus. Gracile nucleus for gracilis, fasciculus gracilis, cuneate nucleus for fasciculus cuneatus. You just remember gracile and the cuneate nucleus, gracile and the cuneate nucleus. When you come to, so over here for the tracts, we have mentioned these points over here. These are important points. Then apart from this, whenever we are talking about the first order neuron, that is the dorsal root ganglia, second order neuron, gracile and cuneate nucleus, and the third order neuron is the VPL of the thalamus, which is ventral posterolateral nucleus. Now coming to the descending tracts. Now when we talk about the descending tracts, we divide it into 2 portions: pyramidal tract and the extrapyramidal. The main is the pyramidal, which is also known as corticospinal, and that is responsible for all skilled voluntary movements. Very, very important. It is responsible for all the skill voluntary movements, and this is the one which crosses at the medulla, specifically at the lower medulla. This is the main tract over here. So first of all, you remember this tract, the pyramidal or the corticospinal. All the other tracts, they are listed under extrapyramidal, in which you should be knowing that the rubrospinal comes over here. Right, the rubrospinal is coming over here. Then a very, very important syndrome over here, that is a Brown-Sequard syndrome. All the symptoms on the same side, only one symptom opposite side, contralateral loss of pain temperature. This you remember, contralateral loss of pain temperature. The rest of the symptom on the same side, ipsilateral hemiplegia as well as the ipsilateral loss of fine touch and vibration. Now, whenever you are remembering this Brown-Sequard syndrome, please remember the symptoms. Okay, you just remember the symptoms, that all the symptom ipsilateral, one symptom contralateral loss of pain and temperature. Ipsilateral hemiplegia, ipsilateral loss of fine touch. If you remember the symptom, you can automatically tell that what fibers are gone. If the hemiplegia is there, of course, the pyramidal tract or the corticospinal tract is gone. If the loss of fine touch is there, of course, the dorsal column is gone. If the loss of pain and temperature is there, of course, the lateral spinothalamic tract is gone. Right? In the neuroanatomy, the Brown-Sequard syndrome you should be knowing well, and this Wallenberg syndrome you should be knowing very well as a clinical question. They can come as clinical question. Then apart from this, for the Weber syndrome, you should be knowing a keyword, cranial nerve 3. Whenever the Weber syndrome is there, always a cranial nerve 3 involvement will be mentioned along with the other neurological symptoms. So cranial nerve 3, Weber's, cranial nerve 12, medial medullary syndrome. Now coming to the lower limb. Now as we talk about the lower limb, inguinal ligament, if we see this image, this is the image of the bony pelvis, in which we know very well that this is the location of pubic symphysis, and these two foramens which we can see on the either side, this is the obturator foramen. These two landmarks are very, very important. Then apart from this, this is the anterior superior iliac spine, this is the pubic tubercle, and the ligament between the two, the ligament between the ASIS till the pubic tubercle is the inguinal ligament. Okay, this is the inguinal ligament. So inguinal ligament, it is between ASIS to the pubic tubercle. It is between ASIS to the pubic tubercle. Then we are having a very, very important point over here, highest level or highest point of iliac crest. What is the vertebral level? L4. The highest point of iliac crest L4, PSIS S2. So highest level of iliac crest L4, PSIS S2. Mid-inguinal point is a midpoint between, it is midpoint between the ASIS and pubic symphysis. Please remember over here, this is pubic symphysis, okay, not tubercle, pubic symphysis. And what is present at this location? Femoral artery. You can even feel the pulsation of the femoral artery at this point. So femoral artery present at the mid-inguinal point. Then at the ASIS, a muscle which is attached is the sartorius muscle. ASIS, a muscle is attached, sartorius. Now coming to the femur, now this is a very, very important image over here. So in the images, we have mentioned this bony pelvis image, very important. And another image is the image of the femur, which is very important over here. And in that, what is important actually is greater and the lesser trochanter. The bigger prominence, greater trochanter, the lesser prominence, lesser trochanter, and the muscles attached to it is greater trochanter gives attachment to gluteus medius and minimus. Okay, all these points, they are important for us. The greater trochanter gives attachment to gluteus medius and minimus, and both this medius and minimus, they help in what action? Abduction at the hip joint. Abduction at the hip joint. Then lesser trochanter, iliacus, psoas major, together known as iliopsoas, and both the muscles, they help in what? Flexion. Both the muscles, they help in the flexion of the hip joint. So you should be knowing well whatever muscles are attached at these 2 points, and we have also mentioned the action, common action of these muscles over here. Then coming to the foot, in the foot, this image is very, very important. you should be able to identify all the tarsal bones. And when you see over here, this one is talus, calcaneum. In front of the talus, you have navicular, and in front of the navicular, you are having cuneiforms, medial, intermediate, and the lateral cuneiform. And this bone in front of the calcaneum is cuboid. Whenever you are identifying this image, if any confusion, you will see navicular is on which side? The navicular is on medial side. This navicular bone, which is most important, it is on the medial side. So you can confirm by the medial side, because the great toe side, the bones are very broad. The metatarsal and the phalanges, they are very broad. So when you see the image, you can tell the great toe, and that is the medial side, and towards that side you are having the navicular bone. Now, coming to the greater and the lesser sciatic foramen, over here, first of all, you will remember the pin. That pin is the structures passing through both greater and the lesser sciatic foramen. What is pin? The pin is pudendal nerve, internal pudendal vessels, and nerve to obturator internus. So these are the three structures which are passing through both greater and the lesser sciatic foramen. Now we say, what is the root value of sciatic nerve? It is L4, L5, S1, S2, S3, and for pudendal nerve it is S2, S3, S4. These two nerves root values are important for you. So sciatic nerve and the pudendal nerve root values, and we have remembered pin for greater and the lesser sciatic foramen. Now when you come to the thigh area, now for the thigh area we say, whenever we are talking about the thigh area, anterior compartment, posterior compartment, medial compartment. Anterior compartment nerve is femoral nerve, posterior compartment nerve is sciatic nerve, medial compartment the nerve is the obturator nerve. These are the nerves for each compartment. So anterior, posterior, in the thigh area or in the leg area, anterior, posterior will always be there, and one extra compartment is there. And in the thigh area we say anterior, posterior, medial. Anterior and the posterior, these are the more important compartments. In the thigh and the leg, you will first of all memorize the anterior and the posterior compartment, and then the another compartment, right? So first of all you will memorize anterior and the posterior. Anterior side femoral nerve, posterior side sciatic nerve, medial side obturator nerve. And in the lower limb we say the actions are opposite. Anterior side muscles help in extension, posterior side muscles help in flexion, they are flexors. So we say anterior compartment is having a common action helping in the extension, posterior compartment is helping in flexion, and the medial compartment is helping in adduction. It is bringing the thighs towards the midline, so it is helping in adduction. So this is for the thigh area. We have talked about the three compartments, nerve of each compartment, and a common action which is done by them. The flexion extension we have mentioned over here is at the level of knee joint, and this adduction we have mentioned over here is at the level of hip joint. So over here, these are the muscles, these are the nerves of each compartment and the action. Then apart from this, whenever we are talking about the anterior compartment, we say main muscle quadriceps anteriorly, main muscle hamstrings posteriorly, main muscles adductors medially. So anteriorly quadriceps, so they are supplied by femoral nerve, they are helping in extension at the knee joint. Posteriorly main muscle hamstrings, so supplied by sciatic nerve, so they are helping in the flexion of the knee joint. Medial side adductor muscles main, so they are supplied by obturator nerve and they are helping in the adduction. So you remember this point over here, anterior, posterior, medial compartment, nerve of each compartment, the common action which is done by them, quadriceps anterior, hamstrings posterior, adductors medial. Okay, you first of all remember this and then we go forward. So we have mentioned this point over here in the thigh region. Then coming to the anterior compartment, femoral nerve is the nerve of anterior compartment, and we say that it is formed by L2, L3, L4. What divisions? It is the posterior divisions. It is the posterior divisions of L2, L3, L4 over here. Now when you see the muscles over here, the muscle which is running obliquely, the sartorius muscle, important muscle for you, the muscle which is running obliquely in the thigh, that is a sartorius muscle. Below that you are having the quadricep group, above that you are having this femoral triangle. In the quadriceps, in the center, rectus femoris, medial vastus medialis, lateral vastus lateralis, and deep to rectus femoris you are having vastus intermedius, and the common tendon is patellar ligament or the patellar tendon. Now over here we say quadricep, we have just mentioned it is helping in the extension at the knee joint. This is the main action over here which you have to remember in this thigh area. Another point you should be knowing is that the sartorius is the talus, it is known as talus muscle, and this is the longest muscle of body. So these are the points which you should be knowing over here in the anterior compartment. In the medial compartment, we have already mentioned adductors, and the nerve is obturator nerve. And now the obturator nerve is formed by anterior divisions. Then as you come to this point over here, we have mentioned guy ropes, three muscles over here: sartorius, gracilis, semitendinosus. Sartorius, gracilis, semitendinosus, they are considered together as guy ropes. Then coming to the femoral triangle. Now when you talk about the femoral triangle, first of all, the medial and the lateral boundary. Now whenever you are talking about the medial and the lateral boundary, remember one thing: medial boundary. That means the muscle on the medial side. Which are the muscles on the most medial side? That is the adductors. Adductors always on medial side. So adductor will always form the medial boundary. Agree to that? So adductor longus is forming the medial boundary, and the lateral boundary is formed by sartorius muscle, which is coming obliquely. So when you see this image, medial boundary is formed by adductor longus, and the lateral side, the sartorius, is coming obliquely. And on the superior aspect, it is completed by a ligament over here, which is the inguinal ligament. It is an inguinal ligament. Now over here we say that specifically it is the medial border of both muscles which are contributing in the boundary. Listen to this word. Which border of the muscle is contributing into the boundaries of triangle? So for example, if you see this image over here, the pink colored triangle is a femoral triangle. And when you see the sartorius muscle, the sartorius muscle is having one border over here. This is one border, and this is another border. Now this border is on lateral side. We say this is the lateral border of the muscle. Okay, this is a lateral border, and this we say is the medial border of the muscle. We are now talking about the border of the muscle. So now you tell yourself which border of the muscle is contributing into this triangle. So we say that this medial border of the sartorius muscle is contributing into the triangle. So it is the medial border of sartorius which is contributing into the triangle. Now exactly in the same way we talk about adductor longus. Now when you are talking about adductor longus, this is the medial border of the muscle, and this is the lateral border of the muscle. Okay, we are talking about the muscle border. And now if you see, it is a medial border which is contributing into the triangle boundaries. Now the best way to remember this is, whenever you are talking about the boundaries, first of all you remember medial boundary, adductor longus, lateral boundary, sartorius. And then just you remember that the two muscles which are forming the boundaries, it is a medial border of both the muscles. Okay, it is a medial border of both the muscles which are contributing. So first you remember these boundaries, adductor longus, sartorius, and then you say medial border of both the muscles. That is the way you remember. Okay. Now coming to the floor over here, for the floor we say that from medial to lateral, the four muscles are arranged one by one, and you remember by this mnemonic API: adductor longus, pectineus, psoas major, iliacus. Medial to lateral, four muscles which are arranged over here. Then as you come to the contents, we very well know, in the contents we remember as van. Okay, we remember by van, and first of all we say lymph node and then van. From medial to the lateral side, if you see from medial to the lateral side, first of all lymph node is present, then VAN, the femoral vein, artery and the nerve, they are present over here. So this arrangement is important, and these are the structures which are in the contents of the femoral triangle. The lymph node over here is actually the deep inguinal lymph nodes. Now we say that the femoral sheath, you can see we have shown some blue color over here. This is the area which is covered by femoral sheath. So the femoral sheath is covering the vessels, and it has included the lymph node also. Which structure is not covered by femoral sheath? That is the femoral nerve. You can see femoral nerve is outside the sheath. Now this is a femoral sheath which is divided into three compartments. This is a medial compartment, this is the lateral compartment, and in between the intermediate. So what is in the medial compartment? You have lymph node. What is in the lateral compartment? You have artery. What is in the middle intermediate compartment? You have the vein. So if you see over here, we have written in the medial, intermediate and the lateral compartment. Now the most important is the medial compartment, also known as femoral canal, and it is having the lymph node. So if separately it has mentioned femoral canal, what is present in the femoral canal? So the answer is lymph node of Cloquet or Rosenmuller. Okay, it is a lymph node of Cloquet or Rosenmuller. On the lateral side, along with the femoral artery, you are having also genitofemoral nerve, femoral branch. It is a femoral branch. Now one more thing, for the femoral canal, if we see this femoral sheath over here, we say that this empty area over here, this empty area, you can see that this conical type of area over here is the femoral canal, and towards the uppermost portion of the femoral canal, this ring type structure is known as femoral ring. This is the femoral ring. Now coming to the adductor canal. Now when you talk about the adductor canal, before we talk about it, you should be having a generalized idea in your mind that the femoral triangle continues below as adductor canal, and adductor canal finishes on the lower aspect at the level of adductor hiatus. These three structures are in continuation. So for example, the femoral artery is passing through femoral triangle, then it passes through adductor canal, and then it exits or leaves at adductor hiatus. And after passing through adductor hiatus, it will go posteriorly to the popliteal fossa, right? So you should be having this idea. Then another thing we say for the adductor canal. Now for the adductor canal, two things you should be knowing: medial boundary, lateral boundary. These are the points which are actually asked, medial boundary and the lateral boundary. So you remember please medial and the lateral. Again over here, when the word medial boundary is there, so I just said for the medial side muscle. So which muscle? Adductor longus again over here. So medial boundary, you remember the medial boundary, medial side muscle, adductor longus. Both for femoral triangle and for the adductor canal, the medial boundary is formed by adductor longus. Now if the medial boundary is formed by adductor longus, then the lateral boundary is formed by vastus medialis. Then it is formed by vastus medialis. Now coming to this nerves over here, for the nerves you should be knowing the root value of ilioinguinal L1, genitofemoral nerve L1, L2. The genitofemoral nerve is a nerve of cremasteric reflex because why is it so? Because it is acting as both afferent and efferent. Right, it is acting as both afferent and efferent. So this is the nerve for cremasteric reflex. Afferent is the femoral branch of this nerve, and efferent is genital branch of this nerve. So when we are talking about genitofemoral nerve, you should be knowing that it is the nerve of cremasteric reflex. Now when you are talking about femoral branch, it supplies skin, and the genital branch, it supplies muscle. The femoral branch supplies the skin over the upper and medial aspect of thigh, and the genital branch, it supplies muscle, cremaster muscle. So this is about the genitofemoral nerve. Regarding the iliotibial tract, on the lateral side, it is the thickening of fascia lata, and we say what three muscles are attached to it. What three muscles are attached to it? One main muscle over here, gluteus maximus. The gluteus maximus, along with that tensor fascia lata, one more muscle is attached to it, which is the vastus lateralis. These two muscles are the main muscles, gluteus maximus and the tensor fascia lata, which is attached to iliotibial tract. Now when you see this image over here, you very well know gluteus maximus. As you remove the gluteus maximus, from above to below you are having four muscles over here, and we say what are the four muscles? First of all, gluteus medius minimus, then you have piriformis, then after that you are having obturator internus, and just below to that you are having the quadratus femoris. So in this order these muscles are present, just deep to the gluteus maximus muscle. Now when you talk about the gluteal region, now when you talk about the gluteal region, for the gluteal muscles you should be knowing the nerve supply, and the action. Very important. Nerve supply and the action. And as we said earlier, we said medius and minimus, they always walk together. Same attachment, same action, same nerve supply. And two structures are there together, medius and minimus. So unity, they are united, so they have power with them. And that is why we say superior gluteal nerve is supplying the medius and minimus. This is just to remember, medius, minimus always together. So unity means power, and power means that superior gluteal nerve is supplying this medius and minimus. So when we are talking about the nerve supply over here, maximus inferior gluteal nerve and medius and minimus superior gluteal nerve. Action by the maximus is extension at the hip joint, and action by medius minimus abduction at the hip joint. This is very, very important. Nerve supply and action. So for medius and minimus, the nerve supply and the action is very, very important. Then apart from this, a very frequently asked question, the quadrant, safest quadrant for intramuscular injection. In the gluteus maximus, it is upper and outer quadrant. Now, if the superior gluteal nerve injury is there, in that we say medius and minimus, they will be paralyzed. Of course, if the superior gluteal nerve injury is there, the muscle supplied by them paralyzed. If they are paralyzed, we say the pelvis falls or sags to which side? Same opposite. It is towards the opposite side. And the Trendelenburg sign is positive, and the walking pattern is changed, and we say the lurching gait is present. If it is unilateral, then lurching gait. If it is bilateral, then waddling gait. So the pelvis sags to opposite side. The sign, Trendelenburg sign, is positive. Which gait? Lurching gait. This is a superior gluteal nerve palsy. Now coming to the posterior compartment of thigh. For the posterior compartment of thigh, we just mentioned sciatic nerve, main nerve. Action is flexion at the knee joint. Which main muscle? Hamstring. So for the posterior compartment, you should be knowing this. Posterior compartment, sciatic nerve, flexion of the hip joint. It is a posterior compartment of the thigh. We are having the nerve, sciatic nerve. We have the flexion at the knee joint, and the muscle is a hamstring. Now another thing which you should be knowing, that in the hamstring, the short head of biceps femoris is a separate muscle. It is not included in the hamstring. The hamstring is actually including all these muscles, the long head and both semi and a part of the adductor magnus. So this you should be knowing for the posterior compartment of the thigh, that in the hamstrings, short head of biceps femoris is not included. Then coming to the popliteal fossa, mainly you should be knowing that what nerves are present over here. So we have sciatic nerve dividing into tibial and common peroneal. If you see this image, sciatic nerve coming from above divides into tibial, which goes directly down, and the common peroneal, it is taking a turn. So these are the nerves which are present in the popliteal fossa. Now as you come to the knee joint, very, very important point over here is the menisci and the cruciate ligament. Now when you see the piece of cartilage over here, this is the meniscus, medial and the lateral, which is more prone to injury. M for medial, M for more. So medial meniscus injury is more prone to injury. And in the center, the ligament which are like a cross, these are the cruciate ligament, and this is providing anterior posterior stability. They prevent any kind of anterior or the posterior dislocation. So we say anterior posterior stability. Then another very important point is locking and unlocking of the knee joint. Which muscles are helping? Locking quadriceps, unlocking popliteus. The muscle name you should be knowing: locking quadriceps, unlocking popliteus. Now coming to the division of the sciatic nerve. We have said that the sciatic nerve divided into tibial nerve and the common peroneal. The tibial nerve runs down on the posterior side of the leg only, so it is also known as posterior tibial nerve, and because it is going on the posterior aspect of the leg, it is a nerve of posterior compartment of the leg, right? The common peroneal nerve, it takes a turn, winds around which part? Neck of fibula. Neck of fibula is on the upper aspect, neck of fibula, then it divides into deep peroneal and the superficial peroneal. The deep peroneal is a nerve for anterior compartment, and the superficial peroneal is a nerve for lateral compartment, in which we say the anterior and the posterior compartment. These two compartments are the main. So anterior compartment nerve is deep peroneal, posterior compartment nerve is tibial nerve. Now over here in the leg area, all the branches which are supplying the leg area, you can see they are ultimately coming from sciatic nerve. Okay, they are ultimately coming from sciatic nerve. Nerve for anterior compartment, deep peroneal, posterior compartment, tibial nerve, and the lateral compartment is superficial peroneal. Again, over here, anterior and the posterior compartment are more important. Whatever muscles are present in these compartments, they will be supplied by this nerve. So first of all, you remember all the nerves of each compartment of leg. Okay, if you remember this page is very important. If you remember this page perfectly, then you are able to answer the questions of the leg. So now over here we have said nerve of each compartment. First of all, you remember the nerve of each compartment. Anterior compartment, tibialis anterior. So that shows it is on the anterior side. Then we have extensor muscles. Extensor we know is on the anterior aspect in the lower limb. So extensor muscle, tibialis anterior, supplied by deep peroneal nerve. Tibialis posterior, posterior side, tibialis posterior, and on the posterior side you have flexor muscles. So they will be supplied by the posterior compartment of the leg. And along with that, we say in the posterior compartment you have popliteus, which is present in the popliteal fossa. So popliteal fossa we know is on the posterior side, and you have calf muscles, soleus and gastrocnemius. So all these muscles over here, all these muscles, they are supplied by tibial nerve. So tibialis posterior, both flexus. Then we have popliteus in the popliteal fossa, and in the calf we have soleus and the gastrocnemius. All the muscles on the posterior side, they are supplied by tibial nerve, and all the muscles on the anterior side, that is anterior and two extensors, they are supplied by deep peroneal. So this is how you are going to remember the muscles. Anterior extensors, of course extensor on the anterior side, so they are supplied by deep peroneal. Then posterior flexors, popliteus, and the calf muscles, soleus, gastrocnemius, they are supplied by tibial nerve. On the lateral compartment, you are having peroneus longus and brevis, which are supplied by superficial peroneal nerve. Now apart from this, we have mentioned the common action also. Anterior compartment help in, all the muscles help in dorsiflexion of the foot. Posterior compartment helps in opposite action, which is plantar flexion. So dorsiflexion when the foot goes up, and the plantar flexion when the foot goes down. Anterior compartment dorsiflexion, posterior compartment plantar flexion. Apart from this, the lateral compartment is helping in the eversion. It is helping in the eversion. So first you remember the nerves of each compartment. Then you mention the muscles, you remember the muscles, and thirdly, the common action which is done by each compartment muscle. Then apart from this, the sensory supply. When you talk about the sensory supply, the deep peroneal and the superficial peroneal, these are the two most important for the sensory supply. The first web space, the skin over here is supplied by deep peroneal, and the rest of the dorsum of foot, you can see the rest of the dorsum of foot is supplied by the superficial peroneal nerve, which is also going towards the lateral aspect of the leg. These two nerves are the most important. Okay, these two nerves are the most important sensory supply over here. So the same thing is mentioned over here, and in this image is important for us. When you see this image, any tendon going to the great toe, any tendon going to the great toe is hallucis. Okay, that is a hallucis. So any tendon which is going to the great toe is the extensor hallucis longus. Any tendon going to the rest of the toes is extensor digitorum longus. It is the extensor digitorum longus. Then the tendon which ends in the middle of the foot, that is tibialis anterior. Okay, that is the tibialis anterior. So this in the foot we say that, or in the leg area we say that this image is the most important for image based question. Then the posterior compartment also we have mentioned. Then one more thing over here, tarsal tunnel syndrome is the compression of the tibial nerve, and only one syndrome in the leg area over here, and we say TTT. No error in this, only one syndrome in the leg area, or we say in the lower limb, tarsal tunnel syndrome, TTT, tibial nerve. It is a tibial nerve compression. Similarly, when we are talking about the bone, fibula, the neck of fibula related to common peroneal nerve, only one bony relation. So that is important, neck of fibula related to the common peroneal nerve. This we have just mentioned, and now coming over here to, this is inversion and eversion. You should be knowing about this inversion, eversion. This is a movement over here, inversion, eversion, and it occurs at what joint? So it occurs at the joints of the foot. Subtalar. Then after that you say talocalcaneonavicular. Okay, subtalar joint, and then you have talocalcaneonavicular joint. So first of all, you should be knowing at what joint, then what are the muscles helping in that. Eversion, you have peroneus longus, peroneus brevis, and peroneus longus, peroneus brevis, and then we say inversion, we have tibialis anterior and the tibialis posterior. And whenever you see the second alphabet of each muscle, that will be helping you to remember E for eversion, I for inversion. So this is important for you, that it occurs at what joint and which muscles. When you compare it with dorsi and the plantar flexion, this is occurring at the level of ankle joint. Now, whenever you are talking about the foot drop, we say it is commonly due to the injury of common peroneal nerve. If the common peroneal nerve by chance is not given, then you can go for deep peroneal nerve. Now, the common peroneal nerve, when it is gone, we will be having the loss of dorsiflexion, loss of eversion, and a lot of sensory loss. There will be a lot of sensory loss. All the symptoms will be seen. But when you talk about the deep peroneal nerve, for the deep peroneal nerve, mainly we have loss of dorsiflexion. Mainly this symptom is there. So that is why we say that we consider it as a second option if it is, if the common peroneal nerve is not given. So the main answer is common peroneal nerve, because it is a very commonly involved or injured nerve. It is related to the neck of fibula. So you can say it is a commonly injured nerve in the leg area, Now coming to the arteries over here, when we talk about the arteries, the femoral artery continues into the popliteal artery present in the popliteal fossa. It divides into two tibial branches. The one which is running on the anterior side is anterior tibial artery, and the one on the posterior side is the posterior tibial artery. So if you see over here, very important, popliteal divides into anterior and the posterior tibial. Anterior tibial continues into the dorsalis pedis, and the posterior tibial continues into the plantar artery. So if you see this image over here, anterior tibial continues on the dorsum of foot as dorsalis pedis, and the posterior tibial artery continues towards the sole of the foot as a plantar artery. And over here we say that most important is the posterior tibial artery. This image has been asked earlier and the arrow has been put over here. So this is the location of posterior tibial artery. Then another point, 4 times this question has been asked. Another point, another time they asked about the pulsation. So you can feel or pulsate this artery between the medial malleolus and the tendocalcaneus with the foot in slight inversion. So this is the point where you will feel the posterior tibial artery between medial malleolus and the tendocalcaneus. It is between the medial malleolus and the tendocalcaneus with the foot in inversion. Now regarding the venous drainage over here, of course, when we are talking about the veins, the superficial vein, you should be knowing that it is great and the small saphenous vein. The deeper veins are according to the name of the arteries. Now the point knowing over here is that perforator, which are the connection between the deep and the superficial vein, what is the direction of the blood flow? The direction of the blood flow from superficial vein to the deeper vein, from superficial to the deeper vein. Now in the perforators which are present, the most important perforator is Hunterian. The location and the connection. It is located in the mid-thigh and it is a connection between the great saphenous vein and the femoral vein. This is the Hunterian perforator. Another is the Boyd's, which is B for Boyd's, B for below knee. B for Boyd's, below, it is below knee. So main is the Hunterian perforator, and you should be knowing that it is in the mid-thigh between the great saphenous and the femoral vein. And we say that if the perforators are disturbed, the walls over here are disturbed, it leads to a condition known as varicose veins. Okay, varicose veins. Now this is the image which is showing the great saphenous vein over here, which is running from the foot to the thigh area over here, and it is running on the medial aspect. And we say that there is an important relation over here. The great saphenous vein is related to a nerve, saphenous nerve. Okay, related to saphenous nerve. Now when you talk about the dermatomes over here, this is the anterior side, this is the posterior side. We have mentioned earlier that on the anterior side, the lumbar, they go down, and on the posterior side, sacral, they go up. This is how you are going to remember. On the anterior side, lumbars they go down, and on the posterior side, sacral they go up. And when you are remembering these dermatomes, lumbar going down, so simple counting is there, and the sacral going up, simple counting is there. Only one difference, and that we remember this one. Only you remember L4 over here. Only this difference is there. L4 is specifically on the medial aspect of the leg. Okay, L4 is specifically on the medial aspect of the leg. You just remember L4. So when you are memorizing, you can see the counting is like simple counting, 1, 2, 3, but over here in the leg the simple counting is not there. We say L4 is on the medial side. If you remember L4 is on the medial side, of course the L5 is on the lateral side, and on the lateral side we say it is going till the great toe. Okay, I got a lot of I was getting the query regarding this L5. According to the recent update, we say L5 is the one which is going till the great toe. Okay, this is the one which is going to the great toe. So what you remember over here? L4. For the others it is simple counting, 1, 2, 3, 4, 5. Now coming to the sacral, when you talk about the sacral, again simple counting is there, S1, S2, S3, S4, S5. So S1 at the heel area, then S2 over here completely on the leg and the thigh area, and in the gluteal region we say S3, S4, S5. So again if you see, the simple counting is there towards the upper side. So this is how you are going to remember the dermatomes: lumbar going down, sacral going up, and in the lumbar you remember only L4, medial aspect of leg. Fine. Now coming to the x-rays over here, this x-ray is important for you, and of course you should be knowing the location of pubic symphysis, which has been already asked, obturator foramen, greater trochanter and the lesser trochanter. All the landmarks over here are important for you. You should be able to identify all these landmarks. So this x-ray is important for you, and you should be able to identify all these landmarks over here. Then another x-ray which is important for you is this view, which is the superior view of the foot. And in the superior view of the foot, when you see this view, you can yourself tell that this is a medial side. It is very broad metatarsal, and this is a lateral side. Then this slightly curved bone which you see is the navicular. In front of the navicular you are having 3 cuneiforms, and on this side you have cuboid. How do you confirm? The navicular, it is present on the medial side. So you are confirmed that this is the navicular bone. This is a navicular bone. Okay, next we will be starting with the abdomen, and before we start with the abdomen, we will just take a break for 5-10 minutes. Okay, and then we will resume the class. A small break for 5-10 minutes, and then we will resume the class. Okay, now coming back over here, starting with the abdomen portion. Okay, let us start with the abdomen portion. Now, in the abdomen portion, a very important point over here is inguinal ligament. We say inguinal ligament is thickening of which muscle? It is a thickening of external oblique aponeurosis. Okay, it is a thickening of the external oblique aponeurosis. If you see this image, the external oblique aponeurosis is this one, which thickens on the lower aspect to form this inguinal ligament. Then another thing over here, we say in the center, this fibrous band which is present is linea alba. Okay, this is a linea alba. And the linea alba is the one where all the three muscles, external oblique, internal oblique, and the transversus abdominis, they come and get inserted over the linea alba. So in the midline over here, you have this line linea alba, and on the lateral aspect, you have this line which is linea semilunaris. Now, between the linea alba and the linea semilunaris, you are having a muscle over here, which muscle is rectus abdominis. Fine. So, you can say that the linea semilunaris is corresponding to the lateral border of rectus abdominis muscle. Now, when the three muscles, external oblique, internal oblique, transversus abdominis, they are coming to the midline over here, they form the aponeurosis, and this aponeurosis near the midline is going either anterior to the rectus abdominis or posterior to the rectus abdominis, and it is forming a sheath, rectus sheath. So, rectus sheath is also contributed by all the three muscles, external, internal oblique, and the external oblique, internal oblique, and the transversus abdominis. The same point have been mentioned over here. We have already mentioned this point. Now, in the rectus sheath, along with the rectus abdominis, we say one more muscle is there which is present, is a pyramidalis muscle supplied by subcostal nerve, which is a T12 spinal nerve, which is a T12 spinal nerve. Pyramidalis is a very small muscle which is present towards the lower aspect. Okay, it is a very small muscle which is present towards the lower aspect of the rectus abdominis. Now, apart from this, regarding about the quadrants, for the quadrants in the abdomen, we say that it is divided into 9 quadrants with the help of 2 vertical planes, which are mid-clavicular plane, and the 2 horizontal planes. What are these horizontal planes? The horizontal planes is subcostal, upper one is subcostal, and the lower one is transtubercular. The mid-clavicular plane, it is from the midpoint of clavicle to the mid-inguinal point. And very, very important, for the subcostal plane, we say it is at the level of L3, and the transtubercular is at the level of L5. So, L3, L5, L3, L5. So, for the quadrants, you are having these 2 planes, and this is at the level of L3, this is at the level of L5, both upper borders. For both, we say it is the upper border which is contributing. So, these are the 2 horizontal planes which are very important. Apart from this, one more plane which you should be knowing is transpyloric plane. The transpyloric plane is the highest plane at the level of L1. This one more plane you should be knowing the vertebral level, L1. So, we mentioned about these planes, subcostal L3, transtubercular L5 for quadrants. Then we said transpyloric L1, one more plane, transpyloric L1. Now, coming to the inguinal region, very, very important. Inguinal region, very, very important. And for the location, we say superficial inguinal ring in which layer? Superficial because it is outer. So, in the outermost layer, external oblique aponeurosis. Deep inguinal ring in the deeper layer. And the deeper layer is which layer? Fascia transversalis. Okay, the word is fascia. The word is fascia transversalis. So, these are the location in which layer it is present, the location on the layers. Then in between the superficial and the deep ring, the passage is known as inguinal canal, which is giving passage to one main structure, spermatic cord. And along with that, one nerve is there. What nerve? Ilioinguinal nerve. In the females, we say that the round ligament of uterus is present over here along with the ilioinguinal nerve. Now, a triangle which is present in the inguinal region is the inguinal, we say it is the Hasselbeck's triangle. What are the boundaries of Hasselbeck's triangle? One boundary we say rectus abdominis muscle, another we say inguinal ligament, and the third we say is inferior epigastric vessels. Just give me a minute over here. So what we have said for the Hasselbeck's triangle, we said one boundary by muscle. So if we see this image over here, one boundary is formed by rectus abdominis muscle, another boundary is by inguinal ligament over here, and the third boundary is by inferior epigastric vessels. Now we should be knowing first of all this, and then we say that for the rectus abdominis, which border. Now if this is the medial side and this is the lateral side, and you see specifically the rectus abdominis muscle, so this is the medial border of the muscle and this is the lateral border of the muscle. And if we say specifically that which border of the muscle is contributing into the boundary, then now you can see it is the lateral border of the muscle. This is the lateral border of the muscle which is contributing into this boundary. So that is why we have written for the rectus abdominis, lateral border of rectus abdominis. It is a lateral border, not lateral boundary, border of the muscle. So we say lateral border of this muscle is contributing into the boundary. Now coming next over here to a very important thing, that hernias which are present, inguinal hernia, femoral hernia. Now the anatomical structure is differing over here. The anatomical points over here, if the swelling is present above and medial to the pubic tubercle, above and medial to the pubic tubercle, then we say it is the inguinal hernia. And if the swelling is on the opposite side, that is below and lateral to the pubic tubercle, then we say that it is a femoral hernia. First of all, this point, in this you remember one point, above and medial. If we say above and medial, that is for the inguinal. Inguinal of course is more important, so above and medial inguinal, and opposite to that will be for the femoral. Now it is passing through what structure? So we say for the inguinal hernia, specifically for indirect. Now the intestinal loop first of all reaches the deep ring, passes through the inguinal canal, reaches the superficial ring, and it can go till the scrotum. So this is the passage of the intestinal loop in the indirect inguinal hernia. If you compare it with the femoral hernia, for the femoral hernia, intestinal loop first of all passes through the femoral ring and then it reaches the femoral canal. Fine. For the peritoneal cavity, we say that it is divided into two portions, lesser sac also known as omental bursa. We know that the lesser sac location is behind the stomach. Whatever space is behind the stomach, that is the lesser sac, and another portion is a greater sac. The communication between the two is known as epiploic foramen. So if you see this image over here, we have mentioned that lesser sac is a small area which is behind the stomach. The rest of the peritoneal cavity is the greater sac. So this is the lesser and the greater sac, the portions of peritoneal cavity. Now next, coming to the arteries of abdomen. The arteries of abdomen, which is the main artery, you very well know, abdominal aorta. The point of termination L4. Point of termination L4. And it terminates into which artery? It terminates into right and the left common iliac artery. So this termination branch is very important, right and left common iliac, which further divides into external iliac and the internal iliac. For the external iliac, we say it is the artery for lower limb. Okay, this is the artery for the lower limb because it continues as femoral artery, and internal iliac artery, we say it is the artery for the pelvis. Okay, if you remember this point, we will be able to tell the branches also. External iliac artery for lower limb, so it continues as femoral artery. Internal iliac artery, as the name suggests, it goes inside towards the pelvis. So artery for the pelvis, internal iliac. Whatever structures in the pelvis and around the pelvis, they will be supplied by internal iliac artery. So abdominal aorta at the level of L4 divides into right and the left common iliac and further into external and internal. So if you see this image, this is abdominal aorta, divides over here into common iliac, and the common iliac further has divided over here into external iliac, which goes in the lower limb, and this another branch is internal iliac, which is going towards the pelvis. Right? This is the basic framework over here. Now the next thing, coming to the branches of aorta, abdominal aorta. Now when we are talking about the branches over here, the main branches, we should be knowing the main branches which can be asked as one-liners. The main branch for abdominal aorta, on the anterior side we say celiac trunk, superior mesenteric, inferior mesenteric. It is in order. You remember in order, celiac trunk, superior mesenteric and the inferior mesenteric. The celiac trunk arises at the junction of T12 and L1, superior mesenteric L1, inferior mesenteric L3. So the same thing we have shown over here, these anterior branches over here, this is in order, celiac trunk, superior and the inferior mesenteric artery. Then you are having the lateral branches. Now which branch is important over here? The lateral branches are named according to the organs where they are going. One important artery is this artery which is running down obliquely, and it is a long artery. This is the gonadal artery. Okay, this one is gonadal artery. This is a gonadal artery. Now when we are talking about the gonadal artery, in this we say that the main is testicular. Mainly they ask about testicular. The testicular arises directly from aorta, abdominal aorta. So testicular artery, then apart from this you should be knowing renal artery. Common iliac we have already mentioned, terminal branches. So these are the main branches over here. And now when you are talking about the celiac trunk, superior mesenteric and inferior mesenteric, if we say that this is a GIT system, it is divided into three portions. This portion is at second part of duodenum, and this junction is at the level of transverse colon. So we say that area above this is supplied by celiac trunk, the area which is between it is supplied by superior mesenteric artery, whatever area is below it, that is supplied by inferior mesenteric artery. So if you remember in this way, that for the whole GIT we have divided into three parts like this. This is the same division we study in the embryology also. The first junction is second part of duodenum, second junction is transverse colon. Whatever area is above second part of duodenum, that is supplied by branches of celiac trunk. Whatever area is in between, this is supplied by branches of superior mesenteric, and in the end you are having the area supplied by branches of inferior mesenteric. Now for the celiac trunk we say what are the main branches. First it gives a branch to stomach, then to spleen and to the liver. Stomach in the middle, the liver on the right side, spleen on the left side. So these three are getting the branches over here, and we say that for the stomach we say the gastric branch is left gastric. Okay, it is the left gastric artery. So these are the three main branches over here which are given off by the celiac trunk. Now when you see these branches over here, any artery which is going to the stomach, this is the left gastric artery. Any artery going to the spleen over here, this is the splenic artery. Any artery which is going to the liver, it is the common hepatic artery. These three branches you can see one is given to each organ. Now apart from this, for the image based question we say that you should be knowing that what are the arteries at lesser curvature, what are the arteries at greater curvature. For that, lesser curvature you have gastric artery, greater curvature you are having gastroepiploic, and the right and the left you can tell accordingly. Then artery which is crossing this junction of stomach and the duodenum is known as gastroduodenal artery. Okay, this is a gastroduodenal artery. So whenever you are talking about the image based question, you remember like this: lesser curvature gastric artery, greater curvature gastroepiploic. Now coming to the other branches over here. Now when you talk about the other branches, first of all you should be knowing the origins of right and the left gastroepiploic artery. Now when you talk about the origins of these two arteries, a very easy way to remember is right gastroepiploic from right side. Which organ on the right side? Liver. So it is a branch coming from common hepatic. Left gastroepiploic from the left side. Which organ is on the left side? Spleen. So it is coming from the splenic artery. This is just a way to remember. So left gastroepiploic, splenic, and the right gastroepiploic is a branch of hepatic, common hepatic. So first you remember this. Then we say that the common hepatic, it actually gives off gastroduodenal, and the gastroduodenal is the one which is actually giving off the right gastroepiploic artery. So mainly you should be knowing the origins of right and the left gastroepiploic artery in the branching over here. Then apart from this, the short gastric artery is another branch which is coming from the splenic artery. So these are the branches which are given off by the celiac trunk. Now, when you talk about the superior mesenteric, the main artery is the appendicular artery, which is coming from ileocolic. So, ileocolic is going to the junction of ileum and the colon, and then it supplies artery to the appendix. And if you see this portion over here, it is starting from inferior part of duodenum, that is the rest of the duodenum or the lower part of duodenum, duodenum, ileum, ileocolic junction, ascending colon, and this is for the transverse colon. So, all the arteries in between, they are the branches of superior mesenteric, and the main is the appendicular artery. And for the lower portion of GIT, it is the inferior mesenteric, and we say the main artery is the superior rectal artery, which is a branch of inferior mesenteric. Now, the two arteries, they anastomose to form the marginal artery, and we say the superior mesenteric is supplying this portion of colon, inferior mesenteric this one, and this is supplied by internal iliac. And there are two watershed areas over here. This is the Griffiths point and this is the Sudex point. When you talk about the Griffiths, it is at the level of splenic flexure of colon over here. It is at the level of splenic flexure of colon, and it is between superior and the inferior mesenteric. Then you are having this, this is a Sudex point, which is at the rectosigmoid junction, and we say it is between inferior mesenteric and the internal iliac artery. These are the watershed areas over here. Now, for the internal iliac artery, we have already mentioned that this is the artery for pelvis. Okay, remember this. So, whatever branches are going, they are going to the organs which are present inside the pelvis or the area around it. Means area around it is like perineum, gluteal region. Now, the two main arteries over here, uterine artery, it is a uterine artery, and another is the internal pudendal artery. Pudendal means to the perineum. So, these are the two main branches coming from the internal iliac. In this way, if you remember, you will be able to remember it for a very longer time. Now, coming to the veins. In the veins, in the abdomen, you have inferior vena cava, you have portal vein. Now, inferior vena cava formation is at level of L5, and the portal vein formation is at a level of L1. And for the portal vein formation, we have SS, two S are there, splenic vein and the superior mesenteric vein. Splenic vein and the superior mesenteric vein. Fine. Now, between the vena caval system and the portal vein, there is portocaval anastomosis, and very important over here for you is the locations. The locations of portocaval anastomosis. Lower end of esophagus, then umbilicus, lower part of rectum and anal canal. These are the locations for portocaval anastomosis. If any portocaval anastomosis over here is enlarged, at the level of lower end of esophagus, it leads to esophageal varices. At umbilicus, it leads to caput medusae. At the level of anal canal, it leads to the hemorrhoids. So, this is regarding the portal vein over here. Then another point which you should be knowing over here is for, again, for the testicular vein and specifically the left. Just remember, left testicular vein drains into the left renal vein. The left testicular vein drains into the left renal vein. Now, coming to the stomach, now regarding the organs, we very well know we have few points regarding the organs which are important to us. How we will be memorizing? First of all, for stomach, at the level of greater curvature, the omentum which is attached is greater omentum, known as policeman of abdomen. Okay, we very well know it is the policeman of abdomen. Now, if the question is asked for stomach bed, a very important point over here is that which structure is not forming the stomach bed, and the structure not forming the stomach bed is spleen. Thus, you should be memorizing over here very well. You should be knowing that the stomach bed is not formed by spleen, and this is the one which is usually given in the options. So, spleen is not forming the stomach bed. The structures which are forming the stomach bed are these, for which we remember by the mnemonic Dr. SSS kills patient mercilessly. But the spleen over here does not form the stomach bed. Now, regarding the spleen, if you see this image over here, the orientation, we are very clear with this. This structure is the spleen over here. This is the spleen on the extreme left side, and on the outer side it is related with this diaphragm, and on the inner side it is related to the organs. Of course, related to the stomach. This is the splenic flexure of the colon. This is the pancreas, in which the head is towards the duodenum, the head of pancreas towards the duodenum, and it is going obliquely upward, so the tail goes till the spleen. So this orientation should be clear to you. And the kidneys, we say, is left kidney is behind the stomach and the spleen, and the right kidney is behind the liver. On the lower aspect of the abdomen, you are having in the center small intestine. On the periphery, you are having this colon or the large intestine. So thereby we say, regarding the relations of the spleen, the inner surface is related with stomach, left kidney, splenic flexure of colon, and tail of pancreas. These are the structures related to inner aspect of the spleen. Then a very, very important ligament over here, splenorenal ligament, or also known as linorenal ligament. Very important ligament from the spleen to the left kidney. What are the contents of this ligament? So in the contents, we specifically say tail of pancreas, splenic vessel. Splenic vessel means artery and the vein both. So these are the contents of the ligament. Then for the spleen, you should be memorizing this one-liners over here: red pulp, white pulp present where? In the spleen. Red pulp, white pulp in the spleen. And in the red pulp, you are having the name structure Billroth cords. So red pulp, white pulp, Billroth cords, they are specific structures for the spleen. Now coming to the large intestine, a very important point over here is, what is the most common position of appendix? The most common position of the appendix is retrocecal. Okay, that is a retrocecal. Then the length of the rectum is 10 to 12 centimeter. For the anal canal, we say 4 centimeter. Then if I talk about the other one-liners over here, so we say Brunner's gland is present where? In the duodenum. Peyer's patch, ileum. Then Hessel's corpuscle is present in the thymus. It is present in the thymus, and the space of Dissay is present in the liver. All these one-liners you should be knowing: red pulp, white pulp, Billroth cords in the spleen, Brunner's gland in duodenum. Then we say Peyer's patch in the ileum, Hessel's corpuscle in thymus, space of Dissay in the liver, islet of Langerhans in the pancreas. So all these are the structures. Then we say the length of the duodenum is 25 centimeter, having these 4 parts. You should be able to identify all the 4 parts, and we say it is the third part which is the longest. Okay, it is the third part which is the longest. Now coming to the liver over here, in the liver you are having a classification. What classification? Conrad's classification. So Conrad classification is for what? It is for the liver. And the right and the left lobe, they are further divided into segments with the help of portal vein and the hepatic vein. So which is there? Portal vein and hepatic vein. Portal vein and the hepatic vein. 4 segments on the right side, 4 segments on the left side, and we say right lobe is 5th to 8th and the left lobe is 1 to 4. For the caudate lobe, we specifically say is the first segment. Now very important over here is the Callot's triangle. Now for this Callot's triangle, this is what we have written over here. These boundaries are according to the latest edition of Love and Bailey surgery book. Okay, so we have mentioned according to that because the Callot's triangle is very, very important for the surgeons for doing the cholecystectomy operation. The different books may be given different, MCQ books may be giving different boundaries for the Callot's triangle. So I'm just telling you over here that we are following the latest edition of surgery's book, standard book, Love and Bailey, right? So Callot's triangle, what are the 3 boundaries? The 3 boundaries are inferior surface of liver, common hepatic duct, and the cystic duct. In that, they have mentioned that the cystic duct along with the gall bladder. The content is cystic artery. So basically, when you're talking about the ducts over here, main is the common hepatic duct and cystic duct. The content is cystic artery, and these are the boundaries of Callot's triangle. So these are the boundaries of the Callot's triangle over here for we say common bile duct and the pancreatic duct. A very frequently asked question: where does it open? It opens in which part of duodenum? Second part of the duodenum. At what papilla? Papilla is major duodenal papilla. So it is a major duodenal papilla. For the pancreas, we have said islet of Langerhans, which is maximum in the tail. Then for the kidney, we said extent is T12 to L3, and the named structure over here is the Malpighian corpuscle and the duct of Bellini. Okay, so now two more main name structure we have mentioned, Malpighian corpuscle and the duct of Bellini. Now in the posterior relations over here, we have mentioned three muscles in the posterior relation of the kidney. It is the psoas major, then we have quadratus lumborum, and then you have transversus abdominis. When we talk about these three muscles over here, I will just take to you this image for the abdominal aorta. Now over here we say, if this is a vertebral column location, then on the either side of the vertebral column there is a vertical muscle. Okay, there is a vertical muscle over here, and this over here also. This is the psoas major. Okay, this is a psoas major. Just lateral to it, a rectangular muscle is there, which is known as quadratus lumborum. Quadrangular in shape. So this is the quadratus lumborum. This one also, and that one also. And as you go more lateral to it, so the laterally the area is filled by transversus abdominis. So the kidney is placed over here like this. So it is related to all the three muscles, the psoas major, quadratus lumborum, and transversus abdominis. So we say that these are the three muscles which are related to the posterior aspect of kidney, and Malpighian corpuscle, duct of Bellini, these are the name structures in the kidney. Extent is T12 to L3. Now coming to the urethra, male urethra, in this very important is when the injury of the bulbar and the membranous urethra occurs, what is the location where the urine is going. Now over here, if we see the bulbar urethra is on the outer side. So just remember the location over here, the bulbar urethra is on the outer side and the membranous urethra is on inner side. Just remember this, bulbar urethra, because it is on outer side, urine will be collecting on the outer aspects, superficial aspect, and the membranous urethra, because it is on the inner side, the urine will be collecting on the inner aspect. This is just to remember. So bulbar urethra outside, you just remember bulbar urethra is towards the outside, so superficial collection of the urine. Membranous is on the deeper aspect, so deeper collection of the urine. When the bulbar urethra rupture is there, we say first of all, whatever urine is coming, it will first of all go to this space just near to it, that is the superficial perineal pouch. Then further it can go to the scrotum, penile region, or further you can see it is going to the entire abdominal wall also. So this is all extravasation of the urine, or we say superficial extravasation of the urine. As compared to this, when we talk about the membranous urethra, in the membranous urethra, when you see this image over here, when the rupture is there in the membranous urethra, first of all urine goes in the deep perineal pouch, and then it is going in the deeper aspect. Towards the deeper aspect over here, it is surrounding the prostate and it is surrounding the bladder, urinary bladder. So the same thing we have mentioned over here, the extravasation of the urine for bulbar and the membranous urethra rupture. Okay, now coming to the uterus over here, when we talk about the uterus, you are having two angles over here, angle of anteflexion and angle of anteversion. Mainly they ask about the angle of anteflexion, how much is the degree, 122, 124, or we say 125, it is between that. So this is the angle of anteflexion. Angle of anteversion is 90 degree. Now when you are talking about the artery over here, we very well know that artery for the uterus is uterine artery, and then it is further branching like this. Now when we talk about their further branches, over here you should be knowing the sequence. Mainly you should be knowing the sequence, and how you remember the sequence with the help of this mnemonic. Mnemonic is, you are really bad singers. you're not bad singers, but this is just a mnemonic. You are really bad singers. And this is a mnemonic. If you remember this mnemonic, you can answer the branching sequence. U, uterine artery, A, arcuate, R, radial, B, basal, and S is spiral. Okay, this is a sequence over here. So you just remember the mnemonic. You are really bad singers. And this mnemonic, by this mnemonic, you remember the sequence. Now coming to the primary supports of the uterus, muscular supports, ligament support, and the uterine angles. That is angle of anteflexion, angle of anteversion. We say in the muscular supports, you have levator ani and the perineal body. In the ligaments, all the ligaments are helping to support the uterus except one ligament which is important for us, and that is broad ligament. For the broad ligament, we say that it does not support the uterus. Okay, so now over here we are memorizing this because it is usually given in the options. Except, when they are giving except, broad ligament is usually the exception. So broad ligament, it does not provide support to the uterus. Now coming to the testes over here, when we talk about the ductal system and we talk about how the sperm is flowing from one duct system to another duct system. So this is the sequence of the ductal system, and the best way to remember this is by this mnemonic SRI. We know starting point is seminiferous tubule, end or it is going and getting stored in the epididymis. So S with S, seminiferous, then next is straight tubule. E with E, before epididymis you have efferent ductule, and R is retrotestis. So you just remember the mnemonic SRI. So you can answer the sequence over here. So we just remember the mnemonic SRI and you can answer the sequence over here. Then regarding the descent of the testis, we say first of all it reaches the deep ring, then passes through the canal, then reaches the superficial ring. And by the 9th month, it reaches till the scrotum. If any arrest in the descent, it is known as undescended. And if the testis is not in this normal path of descent, it is present anywhere else, we say that is the abnormal location, that is the ectopic testis. Now coming to the muscles of perineum. Now when we are talking about the muscles of perineum, one thing you have to remember, levator ani. This is the main muscle of the perineum, and we say that it is having three components: pubo, pubo, ilio. So pubococcygeus, puborectalis, iliococcygeus. Okay, it is ilio and then pubo, pubo. These are the muscles which are forming the levator ani. And when we talk about the ischio-coccygeus, also known as coccygeus, it is not a part of levator ani. And this is the one which is usually given in the exception. So you should be knowing that ischio-coccygeus is not a part of levator ani muscle. It is not a part of levator ani muscle. And now whatever muscle you see in this image, the whole muscle is levator ani muscle. Only a small part which we have shown in the blue color, that is the iliococcygeus. So in the levator ani, which is the muscle not forming its part, it is the ischio-coccygeus. And when you talk about perineal body, for the perineal body, we say in the center of the perineum, this point over here in the center of the perineum, anterior to the anal opening, it is the location of perineal body. All the muscles of perineum, they are getting attached to the perineal body, except, again one exception is there. What is the exception? Now again this is ischio. Okay, over here usually the exception which is given in the questions is ischiocavernosus. So usually the answer which is given as exception is ischiocavernosus. So ischiocavernosus not attached to perineal body. Over here you can also say that ischio-coccygeus is also not attached to the perineal body. So both ischio are separate. But usually in the options they have given ischiocavernosus, so we have mentioned that specifically over here. Fine. Now coming to this image, for this image, first of all you will decide the anterior and the posterior side of the image with the help of the vertebra. This is the spinous process, so this is the posterior side, and then you, according to that, you identify the three layers. Pink layer is the anterior layer of thoracolumbar fascia, blue layer is the middle, and the green layer is the posterior layer of thoracolumbar fascia. Between the anterior and the middle layer, quadratus lumborum muscle. Between the middle and the posterior layer, erector spinae. This is about the thoracolumbar fascia. Now apart from this, on the anterior side, psoas major muscle covered by the same named fascia, that is the psoas fascia. Now as we come over here in this one more point, you should be knowing neurovascular bundle. The neurovascular bundle is present between which two layers? It is between the internal oblique and the transversus abdominis. Now coming to the embryology portion. Now in the general embryology, very important over here is the embryonic phase. You should be knowing that embryonic phase, it extends from 3rd to the 8th week of intrauterine life. This is the most commonly asked phase. So you are having 3 phases: germinal, embryonic and fetal. Embryonic is in the second phase over here, which is 3rd to the 8th week. Very important over here. Now in the embryology portion, usually we study embryology in the end, and we say that you have to learn main things in the embryology. So if you don't get, like, though you should study completely about embryology, but if you want to quickly revise, I will say that quickly revise the highlighted points, because they are having more chances of being asked in the questions. So whenever you are studying embryology, do focus on these highlighted points and make it sure that you remember all these points. So now embryonic phase, 3rd to 8th week. Then for spermatogenesis, we say location. The location is seminiferous tubule. Then duration 74 days. It is, the sperm is stored and it gains motility where? It is in the epididymis. It is in the epididymis. Now when you are talking about the steps over here, these are the various steps. First of all, spermatogonium, then spermatocyte, then spermatid, and lastly the formation of spermatozoa. Over here you will remember the main is primary and the secondary. The primary spermatocyte 46 chromosome and the secondary spermatocyte 23. 46 means diploid, and the diploid is also written as 2n, and secondary is haploid, which is also written as 1n. Okay, this are the terms which are used for this. So primary and the secondary. Primary spermatocyte, primary word is always 46 chromosome, either it is primary spermatocyte or the primary oocyte. Secondary spermatocyte or secondary oocyte is having 23 chromosomes. Fine. Now the next step, last step over here, spermiogenesis, is simply the change in shape of the cell. It is a part of spermatogenesis, and the final structure is this, in which we say head is having nucleus and this middle piece over here is having the mitochondria. Okay, these are the main structures over here. Apart from this, the acrosomal cap is having the Golgi apparatus, but these two are the main components which are asked very frequently. Now when you see the oogenesis, it is exactly the same, but what you will remember over here is polar body formation. The polar body is formed in oogenesis, and then in the oogenesis we say that arrests are occurring. First of all, we say all the primary oocyte, they are formed before birth. Now the cycle is arrested at this point. Now very important over here, when you are memorizing the this arrest over here, 2 arrests are there, 1 arrest, 2nd arrest, and it is very important that you should be knowing that the arrest is released at what time. That is a more important point. Now the first arrest is released before ovulation, so it is before ovulation, 24 to 36 hours before ovulation, which is at puberty. And we say second arrest is released at fertilization. It is released at fertilization. So the first arrest is released before ovulation and the second arrest is released at fertilization. In the first arrest, the primary is converted into secondary oocyte. The primary is converted into secondary oocyte. And in the second arrest, when it is released, the secondary oocyte is converted into ovum. So these 2 arrests, you should be knowing that when they are resumed. When they are resumed, the 2 arrests are released at what time? So first arrest released before ovulation, second arrest released at fertilization. Now coming to this image is very important. When you see this image, first of all, primordial follicle, around oocyte, 1 layer of cell, primordial. If multiple layer of cells, it is primary. If cavity starts developing, or we say antrum starts developing over here, this is a secondary. And when the antrum, it has increased in size properly and the follicle size also increases, this is the Graafian follicle, which is a mature follicle over here. These are the 4 follicles in this secondary and the Graafian follicle, because they are having antrum. Okay, because because we can see they are having the antrum over here. So these two follicles are known as antral follicles. Okay, these two are known as antral follicles, and before to this, the primordial and primary, they are known as pre-antral follicle. We have mentioned this over here, antral follicle and the pre-antral follicle. So this is the antral and the pre-antral follicle. Then as we come back to this image, now we can identify all the cellular stages. 1 is primordial, 2 is primary, 3 is secondary, 4 is Graafian. Then in the 5th, the ovulation is occurring, and the 6th is corpus luteum, which is yellow colored in structure. It degenerates to form 9th, which is which is corpus albicans, which is whitish in color, and we say it is a fibrous scar-like tissue. All these cellular stages present in the ovary. And if you see this ovulation, the structure which has come out, now this structure, it reaches towards the fallopian tube, and this is actually the secondary oocyte. And when you see the secondary oocyte over here, it is having a blue covering, which is a zona pellucida, and outer to it cellular layer, which is the corona radiata. Now when we are talking about the fertilization, a very important point over here is what is the location of the fertilization. The location is ampulla of fallopian tube. It is an ampulla of the fallopian tube. First step, capacitation, and the last step, zona reaction. They are important for us. We say capacitation, it occurs in the female genital tract. More commonly, it occurs in the fallopian tube. Okay, it occurs in the more commonly in the fallopian tube, but it can start anywhere. So that is why we have written over here, female genital tract, and more commonly occurs in the fallopian tube. Duration is 7 hours. This is the capacitation process. Then zona, last step, it occurs to make the zona pellucida impermeable to the other sperm. So it is basically preventing polyspermy. Last reaction, zona reaction. Now when the fertilization has occurred, now the development starts, and the first week of development is the most important week. So I'm putting a star over here. The most important is the first week. The questions are more commonly asked on the first week. Now in the first week, we say most commonly it is asked morula. It is the 16 cell stage, and it is formed on which day? Third day. Formed on third day, and this is a morula which enters the uterine cavity on the 4th day. After that, 4.5 day, blastocyst is formed, and this blastocyst undergoes implantation on which day? 6th day. Now the blastocyst, we say, is having this structure, inner cell mass and outer cell mass. Now at this point, the inner cell mass is the one which is given the term as embryoblast, and this is the one which is going to form the future embryo. So inner cell mass is known as embryoblast, which is going to form future embryo, and outer cell mass is known as trophoblast. The implantation, we have said that the blastocyst is going to do implantation, which is interstitial implantation towards the posterior wall of uterus near the fundus. So the first week of development is the most important over here. Okay, the first week of development, all the points are important for us. Then various things are happening in the second week and the third week. Now I will directly come to the third week. When we talk about the third week, 2 points are very important over here. Third week, 3 germ layers. So 3 germ layers in the third week of intrauterine life. First layer formed is endoderm. So 3 germ layers in third week. First layer formed is endoderm. Then another important structure which is formed over here is a notochord, and it helps in the formation of neural tube, but itself it disappears. So what is the adult remnant of notochord? The adult remnant of notochord is nucleus pulposus of intervertebral disc. So these points are important in the third week. 3 for 3. First layer formed endoderm. Adult remnant of notochord is nucleus pulposus of intervertebral disc. Another point for the intraembryonic mesoderm, we have mentioned the divisions over here. And when we specifically talk about the paraaxial mesoderm, it is also known as somites. Paraaxial mesoderm somites, it is helping in the formation of ribs and the vertebra. So these are the points which you should be knowing which can be asked as questions. So we are discussing all those points. Now coming to the placenta, for the placenta development, this is important that what are the two components of the placenta. Now what are the two components? Decidua basalis and the chorion frondosum. Decidua basalis is a maternal component and chorion or the chorionic frondosum is a fetal component. These two components together, they are forming the placenta. So this placenta is important for you. Then when we are talking about the chorion frondosum is actually having chorionic villi, which are finger-like projections, and we are having three stages over here: primary villi, secondary villi and the tertiary villi. Primary villi is mainly having ST and CT, syncytotrophoblast and cytotrophoblast. And now when one more component is added, we say it becomes secondary villi. What component is added? Extraembryonic mesoderm. And in this, when fetal blood vessels are added, we say it is the tertiary villi, that is a mature villi. So one component is added. Now talking about the placental barrier, it is the layers between the maternal and the fetal blood, and we say these are the layers which are contributing into this placental barrier, that is ST, CT and extraembryonic mesoderm, EEM. Apart from this, the endothelium of fetal blood vessels. At or after 20 weeks, the layers are reduced, and we say the main layer which is present over here is ST, which is syncytotrophoblast, which remains over here. Now coming to the umbilical cord, this point is very important. How many umbilical artery, how many umbilical vein? So two umbilical artery, one umbilical vein. In the one umbilical vein, which one? It is the left umbilical vein. This is a very easy and a frequently asked question. Then coming to the adult remnants of this, when we talk about the adult remnants, the most important adult remnant is umbilical vein. Umbilical vein forms ligamentum teres hepatis. This is the most important adult remnant. Venosus, venosum, arteriosus, arteriosum. Umbilical artery forms umbilical ligament, median umbilical ligament. And its proximal part, it persists at superior vesical artery. But the most frequently asked is the umbilical vein, which is ligamentum teres hepatis. Ligamentum teres hepatis. Now coming to the systemic embryology. Now in the systemic embryology, all the congenital defects, around 8 to 10 congenital defects we mentioned, all are important for you. You should be able to tell the underlying defect. If the image is given or if the condition is given, symptoms are given, you should be able to tell what is the underlying defect. So we will be mentioning that. First of all, the development of central nervous system, we say neural tube is there. Okay, the neural tube is the one which is responsible for formation of the central nervous system. Formation begins 3rd week, completes 4th week. Okay, the neural tube, we are saying neural tube formation. So neural tube formation begins in 3rd week and the neural tube formation is completed in the 4th week. And when the neural tube is formed, so we say there is a fusion, and we say the fusion, it begins at the neck level and then it goes on the other side. So then fusion, it begins at the cervical level. Now a very, very important point over here is its cranial and the caudal neuropore. The cranial and the anterior neuropore, or caudal and the posterior neuropore. Normally, cranial neuropore close at 25th day and the caudal will close at 28th day. If there is any defect of closure in the cranial neuropore, it leads to anencephaly. And if there is any defect in closure of caudal neuropore, it leads to spina bifida. The congenital defects, very important. If this image is given to you, we know that this is anencephaly and this is due to the defect in the closure of cranial or the anterior neuropore. And this condition given over here is the spina bifida, due to defect in closure of caudal or the posterior neuropore. So these two images are very important for the congenital defect. Okay, you should be able to identify the congenital anomaly and then to tell the underlying defect. The underlying defect we have mentioned over here, defect in closure of this cranial and the caudal neuropore. So wherever we mention the congenital anomaly is very, very important. Then apart from this, specifically for pons and cerebellum, we say the part which is contributing is rhombencephalon. So rhombencephalon specifically for pons and cerebellum. Pons and cerebellum. In the neural crest cell, we say specifically it contributes in the formation of upper 4 structures which are the most frequently asked, we say it is the Schwann cell, odontoblast, melanoblast, and adrenal medulla. Okay, it is the adrenal medulla. These 4 structures are very, very important. So, Schwann cell, melanoblast, odontoblast, adrenal medulla. Now, coming to the GIT development, in the GIT development, gut tube. For the gut tube, this image you have to remember. If you remember this image, you can answer a lot of questions. Now, in this image, first of all, we have mentioned 2 junctions. First junction, second part of duodenum, which is at the major duodenal papilla. Second junction, transverse colon at the junction of right 2/3 and the left 1/3 of the transverse colon. Now, whatever portion is above the second part of duodenum, it develops from foregut. Whatever portion is in between it, it develops from midgut. And whatever portion is lower to it is by hindgut. And accordingly, we say the artery of foregut, celiac trunk, artery of midgut, superior mesenteric artery, artery of the hindgut is inferior mesenteric artery. Now, apart from this, we say depressions are there from outside on the cranial most side and the caudal most side. Towards the cranial side, you have stomodium, which forms the future oral cavity. And towards the caudal side, you have proctodium, also known as anal pit, which forms the lowermost part of the anal canal. So, we say lower part of anal canal. So, these are the structures which are completely contributing in the formation of the GIT. And if you remember this image, you are able to answer the questions accordingly. So, this will be very helpful. Now, over here, apart from, if I talk about the foregut, so apart from GIT components, it is also giving rise to the organs which are present nearby. So, what are the organs nearby over here? We are having lung, trachea, and lower down liver as well as the pancreas. And there are buds which are giving rise to it. The respiratory bud or diverticulum, it forms trachea and the lung. The trachea is separated from the esophagus by a septum tracheo-esophageal. Trachea, between trachea and esophagus, tracheo-esophageal septum. Any defect in the development of this septum, of course, it will lead to tracheoesophageal fistula, the condition which we have shown over here, the tracheoesophageal fistula. Then another important is the pancreatic bud over here. One is the respiratory bud, another is pancreatic bud. 2 pancreatic buds, ventral and the dorsal. You remember for the ventral. Ventral forms lower part of head and uncinate process. The ventral forms this portion and the rest of the portion is formed by dorsal bud. So, if you see this image, the ventral bud is forming the lower portion and the dorsal bud is forming the rest of the pancreas. Now, the ventral and the dorsal bud, they fuse to form the complete pancreas. If there is any non-fusion, it will lead to a condition known as pancreas divisum. And again over here, these are the 2 congenital defects. This is the congenital defect we are mentioning, very important. Most common congenital anomaly in the development of pancreas is pancreas divisum. Another important anomaly is this anomaly, annular pancreas. You should be able to identify it. In the annular pancreas, what you see, the pancreatic tissue is surrounding the duodenum. This is the annular pancreas. Okay, now coming to the midgut. Now, in the midgut, the most important anomaly is this one, which we can see, this has been mentioned over here. What we see, midgut is having a communication at the level of umbilicus with a duct. A duct is there in between. That duct is vitreointestinal duct. So, it is between midgut and the umbilicus over here. Now, if it is completely patent, completely it remains, then we say it leads to the fistula, vitelline fistula. And whatever material is present in the midgut, the feces or the meconium, it can come out at the level of umbilicus. So, very, very important, if the vitreointestinal duct is completely patent, vitelline fistula or the fecal fistula, what is the specific symptom over here? That the fecal material or the meconium comes from umbilicus. So, if the fecal material meconium comes from umbilicus, it is vitreointestinal duct. If fluid and urine comes from the umbilicus, then we say that is a allantois. That is a allantois. So, this is the vitreointestinal duct. This is the main anomaly over here. Apart from this, if we see this one, we say that some part of the vitreointestinal duct is patent or we say the proximal part is patent, and it is leading to a pouch kind of structure known as Meckel's diverticulum. So when we talk about the proximal part, when we talk about only the proximal part which is patent, then it leads to the Meckel's diverticulum. So among the two, the main is Wittlein fistula, and another one which you should be knowing over here is Meckel's diverticulum. Now in the midgut only, we say that physiological hernia occurs. The midgut loop, it goes outside the abdominal cavity for a shorter time. Because it is going outside the abdominal cavity, it is a normal process. It is known as physiological hernia. And when it returns back, it is known as return of midgut, or also it is termed as reduction of physiological hernia. When it is returning back, it undergoes rotation and then it comes back. So hernia is at 6th week, reduction or return of the midgut loop is at 10th week. How much rotation? 270 degree in the anti-clockwise direction. What is the axis of rotation? That is the superior mesenteric artery. And why is it happening? Because the midgut loop, they grow very fast. Until that time, the abdominal cavity has not grown properly. So for a shorter duration of time, the midgut loops, they go outside. When the abdominal cavity grow in size, the midgut loop, it returns. If the midgut loop, it does not return, then it will lead to an anomaly which is known as omphalocele. Now this is a very, very important anomaly over here. If you see this image, you should be able to identify. It is omphalocele, also known as exomphalos. And what is present over here? We say it is a non-return of midgut loop, or we can say non-reduction. And what is present? The intestine, they are present at the level of umbilicus and they are covered by amniotic membrane. This is a specific point for omphalocele. This is very, very important. Then apart from this, this is a very important, and this is one of the expected question. Apart from this, you should be able to differentiate it with the gastroschisis. In this, the intestinal loop, they come out, they are not covered by amniotic membrane. And when we see the gastroschisis, it is basically the defect in the anterior abdominal wall. So if the anterior abdominal wall fusion is not proper, a gap is left, and when the child takes birth, through that gap, the intestinal loops, they can come out, and they are not covered by any amniotic membrane. So you will see just the intestinal loop, they are lying outside, not covered by amniotic membrane. Over here, omphalocele, very, very important. Now coming to the hindgut. In the hindgut, we say all rest of the portion of the GIT is formed, and one extra structure is urinary bladder. How it is formed? We say cloaca, which is the lower part of the hindgut. It divides into two portions, urogenital sinus and primitive rectum. According to the name uro gives rise to urinary bladder except the trigone, and the primitive rectum, it gives rise to the rectum and the anal canal. Important for us is the cloaca, which forms urogenital sinus, and the urogenital sinus forms urinary bladder except trigone. Now a very, very important point over here is this anomaly. What is this anomaly over here? We say that allantois. It is a structure which extends from urinary bladder to the umbilicus. Normally it will obliterate. If it remains patent, then a fistula is formed over here, and through this fistula the urine can come out at the level of umbilicus. So we say that it is known as a urethral fistula. So if the allantois is completely patent, it leads to urethral fistula. And what is the specific symptom over here? The urine or the fluid, it comes from umbilicus. So if urine and fluid is coming from umbilicus, that is the defect in allantois. If fecal material and meconium is coming from the umbilicus, the defect is in vitreointestinal duct. Now coming to the mesentery, for the mesentery you will remember dorsal mesogastrium. Okay, you remember this one. Dorsal mesogastrium giving rise to the greater omentum, gastrophrenic ligament. Then you are having these two ligaments which are the ligaments of the spleen. So these are the structures which are formed by the dorsal mesogastrium or the dorsal mesentery, and mainly we say that the greater omentum is formed by dorsal mesogastrium. In the organ which develops in the dorsal mesogastrium, that organ is spleen. Okay, that organ is the spleen. Now further, when we are coming to the genitourinary system, over here you are having mesonephric duct and paramesonephric duct. The mesonephric duct, you remember, is for the males, and the paramesonephric duct is for the females. Okay, this you remember. So mesonephric duct is forming the male reproductive structures, paramesonephric duct is forming the female reproductive structures. This, first of all, this basic thing you should be knowing. Then apart from this, we say the main structures formed by mesonephric duct is, it is also contributing into urinary component. It forms the trigone of the bladder and it forms a ureteric bud. And very important, we say it contributes in the formation of the ureter. So this urinary component is formed by mesonephric duct. Then in the females, the mesonephric duct, it degenerates to form adult remnant. The adult remnant are epophoron, paraphoron and the Gartner's duct. So for the mesonephric duct, urinary component and its adult remnant are important. Then we have said mesonephric duct for males, paramesonephric duct for females. In the paramesonephric duct, we say that it is forming all the structures of the female reproductive system, but the lower part of vagina, is contributed by the urogenital sinus, which is having a contribution sinovaginal bulb. So this is contributed by urogenital sinus, sinovaginal bulb. Now the other structures over here, in this we say most important is the gonadal or the genital ridge. The gonadal ridge, it gives rise to the testis or we say ovary. And the genital swelling, it forms labia majora or the scrotum. And these structures are known as, they are the homologous structures or the homologous organs. More frequently asked is gonadal ridge or the genital ridge. This is more frequently asked. And these two are most important among the whole table. Now coming to the development of urinary system, we have mentioned all the components. Kidney is developed from metanephros. In this you have to remember the word is metanephros, because other options will be mentioning pronephros, mesonephros, metanephros. So it is a metanephros which is developing the kidney, which is forming the kidney. Now regarding this congenital defect over here, this congenital defect, again this is important, lower poles fuse, so you know that this is a horseshoe kidney. Now when the horseshoe kidney, when the kidney is trying to go up, when it is ascending up, because the lower poles are fused, we say this horseshoe kidney is arrested, and now arrested by what structure? So it is arrested by a structure, inferior mesenteric artery, and due to this arrest, the lower fused part will be lying at the level of L4. Now coming to the development of the diaphragm, in this we say the most important are two structures, septum transversum and the pleuroperitoneal membrane. These two are the main structures forming the diaphragm. And when we are talking about the structures over here, main two structures, septum transversum, pleuroperitoneal membrane. The other components, if you see, it is written as lateral body wall mesoderm, dorsal mesentery of esophagus. So even if you remember the word lateral and dorsal, so there is a contribution will be coming from lateral side, and there will be a small contribution coming from the posterior or the dorsal side. So the main two components, septum transversum, pleuroperitoneal membrane. When you see this image, you first of all decide anterior and the posterior side on the basis of vertebra. So this is the posterior side. Now on the anterior side, the whole area is developed by septum transversum. On the posterior side, this orange colored area on either side is developed from pleuroperitoneal membrane. It is developed from pleuroperitoneal membrane. These are the two main structures which you should be able to identify in the diaphragm. Then apart from this, if you see any contribution from lateral side, so of course that will be lateral body wall mesoderm. The word will be there, lateral. Any contribution on the lateral side, lateral word will be mentioned, lateral body wall mesoderm. Any contribution, you can see this projection over here which is on the posterior side. So this is a contribution on the posterior side, dorsal word will be there. The dorsal word will be mentioned, dorsal mesentery of esophagus. So according to this, you will identify the various landmarks over here. Now coming to the development of head and neck, in which we say we are having this pharyngeal arch 1, 2, 3, 4, 6, which is mesoderm in nature, covered on outside by ectoderm, and these depressions are known as ectodermal clefts. covered on inner side by endoderm, and these depressions are known as endodermal pouches. In the arches, we say very, very important first arch. You have to remember the first arch by heart, and how you are going to remember by the mnemonic MASTI. M is the predominant letter. Any structure starting from M is for first arch. So you can see a lot of structures from M. Then A is 2 anteriors, S is sphenoid, T 2 tensors, I incus. So the mnemonic MASTI, M alphabet for the first arch, A anteriors, S sphenoid, T tensors, I incus. This is how you are going to remember. And when we say what are the main structures over here, mandible, muscle of mastication, nerve, mandibular nerve, artery, maxillary artery, all starting from M. All starting from M. And one more important structure, sphenomandibular ligament. These are the most important structures for the first arch. But you should be knowing all these structures. And this is how you are going to remember. So the first arch we remember perfectly, completely. For the second arch, we say the mnemonic is right SPF. And the main structures over here is stapes, stylet process, artery starting from S, stapedial artery, and the nerve F, facial nerve. This is a facial nerve. This is for the second arch, the 4 most important structures which are asked in second arch. Now coming to the other arches, mainly we say the arteries developing from these arches are asked. When you talk about the third arch, it is the giving rise to the carotid arteries. All the carotid arteries, common, internal and the external. Then for the fourth arch, specifically on the left side, specifically which side? Left side is forming the arch of aorta. So for the fourth, on the left side, arch of aorta. For the sixth, it is contributing in the formation of ductus arteriosus, the ductus arteriosus. Now coming to the pouches, first pouch contributes in the depressions in the ear. So from the inner side, eustachian tube, middle ear cavity and the mastoid antrum, they are present in the continuation, and this whole depression we say is contributed by first pouch. So first pouch is for the ear, second pouch is for the tonsil. Very, very important over here. Which tonsils? Most important over here, second and third. Okay, second and third are most important, in which we say the third is of course more commonly asked. So second and third pouch, they are more important. In the arches, first arch is very important, and for the rest of the arches, arteries are very important. And in the second arch also we have mentioned artery, nerve and 2 main structures. Now when we talk about the pouches, second pouch and the third pouch, very important. Second pouch, palatine tonsil, and the depression for that, tonsillar fossa. The third for the third, mnemonic is third, TH, thymus, I is the inferior parathyroid. If the inferior parathyroid is coming from here, the next pouch gives rise to the superior parathyroid. Then ultimobranchial body, it is forming the parafollicular C cells, and we say that the neural crest cells, they migrate over here, which contribute in the formation of the parafollicular C cells. So ultimobranchial body, it contributes in the formation of parafollicular C cells of the thyroid gland. Now when you talk about the tongue development, you should first of all remember 1, 3, 4. 1, 3, 4. Starting from, we know that the tongue is divided into 3 parts. So 1, 3, 4. The development of the tongue is 1. Anterior 2/3 is formed by first arch, posterior 1/3 by third arch, and the posterior most part by fourth arch. So 1, 3, 4. The next thing you will remember is what are the components. Lingual swelling, tubercular impar, and another component is hypobranchial eminence. You please remember these components over here: lingual swelling, tubercular impar, hypobranchial eminence. These points you should be knowing for tongue. Okay, you should be memorizing for the tongue. Now coming to the development of the face, when we talk about the development of face, the development of the lips over here. In this you can see that the upper lip is formed by the fusion of 2 structures, which is central part of upper lip, medial nasal, and the lateral part is formed by maxillary. If there is any non-fusion, at the level of upper lip, it leads to the cleft lip. Now this is another congenital anomaly which is very important and you should be able to answer. This is a cleft lip. It is due to the non-fusion of medial nasal process and the maxillary process. So medial nasal over here and the maxillary process over here, non-fusion of these 2 processes, it leads to cleft lip. Then coming to the development of heart, over here an important structure is fossa ovalis. We say the fossa ovalis is a remnant of. what structure? The fossa valis is a remnant of foramen ovale. This is the first best answer. If it is not given, then you can go for septum primer. So first best answer, foramen ovale. If it is not given, then you can go for septum primer. This is for the fossa valis. Then apart from this, for the tympanic membrane, we say it is formed by all the three germ layers. For the thyroid gland, it develops from thyroglossal duct. For the pituitary gland, it develops from the Rathke's pouch. It develops from the Rathke's pouch. Now coming to the histology portion, in the histology portion you should be knowing the epitheliums which are present at the different location. Usually the question which is asked is what epithelium is present at this location, or they can say that at this location what epithelium, like vice versa the question can be asked, and they usually ask about the location. Simple squamous epithelium, the most important and frequently asked question is alveoli of lung. In the alveoli of lung, simple squamous. Apart from this, it is also present in the endothelium of blood vessels. Then the simple cuboidal epithelium, it is in the thyroid gland. This specific example, thyroid gland, is for simple cuboidal. Also present in the germinal epithelium of ovary. Then as you come to the simple columnar, it is the epithelium of GIT system in the stomach and the large intestine. The simple columnar. The simple columnar with cilia is in the uterus and the fallopian tube. And when you talk about the simple columnar with microvilli, it is specifically present in the gallbladder and small intestine. So it is specifically present over here, and in the gallbladder we use the term as brush border appearance. So in the GIT system, main epithelium is simple columnar, and towards the upper part of GIT and the lower part of GIT we have non-keratinized stratified squamous epithelium. In the non-keratinized, you can see in the oral cavity, tongue, tonsil, oral surface of epiglottis and esophagus. Till this point, non-keratinized stratified squamous, and the lower part of anal canal also. And in the middle we have the simple columnar. So when you are talking about stratified squamous epithelium, keratinized only in the skin and non-keratinized is present at all these locations, in which we say the most important location is tongue, tonsil, esophagus, cornea and the vagina. These are the most important locations which you should be knowing for non-keratinized stratified squamous epithelium. Now coming to this epithelium, which is the most important epithelium over here, that is in the trachea, we say, for the trachea we say that the epithelium which is present in the trachea is the pseudo-stratified ciliated columnar epithelium. It is the epithelium of respiratory system, so it is also known as respiratory epithelium. This is in the trachea. Then another transitional, it is the epithelium of urinary system, so it is also known as urothelium, specifically present in ureter and the urinary bladder. Ureter and the urinary bladder. Now coming to the cartilages, we are having three type of cartilages. Mostly commonly we say that hyaline is there. Elastic cartilage is mainly in the ear. E for E, we say E for ear, ear pinna, external acoustic canal or the eustachian tube, and E for epiglottis. Then we say fibrocartilage is present at specific locations only. If I say what are the main example of each cartilage, trachea, very well you should be knowing trachea. In the trachea, hyaline cartilage, in the epiglottis elastic, and in the intervertebral disc it is a fibrocartilage. It is a fibrocartilage. Now the cartilage which is not covered by a membrane, that is the perichondrium, that is the fibrocartilage, and the cartilage which can ossify with age which can ossify with age is the hyaline cartilage. Now over here we have done with all the whole workbook, and now I will just quickly go through these images also, and you should be aware of all these landmarks. Now in the thorax portion we have two sections over here. One is section 1, section 2. Now when you take section 1, so this is a level of section 1, this is a level of section 2. Now for understanding this, you already know this image, and when we see this image, On the posterior side, this is the vertebral column. In the middle, this is the heart. On the anterior side, this is a sternum, right? This is the sternum, this is the heart, this is the vertebral column. Between the heart and the vertebral column, this pink colored line which we have shown is the descending aorta. In front of the descending aorta, you have esophagus. You are having the esophagus. So when we see these structures, very important point over here is that just in front of the vertebral column, whatever structure is present, that is descending aorta. Just keep that thing in mind. When you see any transverse sections and in the front of the vertebral column, you see a round section, exactly in front of it, you have descending aorta. Okay, that is descending aorta. And as you go in front of the descending aorta, what is this? Esophagus. So this is the arrangement of structures over here. If you take a section at this level, what you will see on the anterior side, sternum, then heart, then you will see on the posterior side, this is a vertebral column, in front of it, descending aorta, in front of it, esophagus. So if you take a section over here, this is a section. If you see this section over here, this is a section. Whenever you are seeing the section, the small component over here, this is the sternum. Okay, this is the sternum, and a bigger component which is present over here, this is the vertebral column, by which you decide the anterior and the posterior side. In the middle over here, whatever structure is present, this section is a section of the heart. And now as you go in front of the vertebra, now when you go in front of the vertebra, the first section which you see is the section of descending aorta. This is a section of the descending aorta. Then just in front of this pink section, you can see this green section. This is a section of the esophagus. So vertebra, descending aorta, esophagus, and then you see the section of the heart, right? So you are clear with this portion over here. Now when you see the heart over here, in the heart we say that the chamber of the heart which is present on the most posterior side over here at this location, this is the left atrium. So the chamber of the heart which is present on the most posterior side, that is the left atrium. This is for the section 1. Okay, now coming to another section. If I come back over here, the section 1 has been asked twice, and the section 2 we should be knowing. This is another section which is important over here. The section 2, you can see we have taken higher up, and we can see we have taken above the heart. So we cannot see the section of the heart over here. And what we will see, the section is going like this. So we will see one round section of aorta in front of the vertebral column, and apart from this we also see one big round section anteriorly, which is the section of ascending aorta. So whenever you are talking about the sections of aorta, it appears to be round in shape. So one section will be seen in front of vertebral column and one more section will be seen anteriorly. So this is a section of descending aorta and this is a section of ascending aorta, right? This you should be clear. So two big round section you will see in front of vertebral column, descending, and as you go anteriorly, that is ascending aorta. Now descending aorta is related to which structure? It is related to esophagus. And ascending aorta, if you see, it is related to which structure? It is related to superior vena cava. So near to them, near to the descending aorta, you will see a smaller section of esophagus. Near to the ascending aorta, you will see a smaller section of superior vena cava. So when you see the section 2, this is a section 2 over here. And now when you see the section 2, again over here, this is the sternum, and this big structure which you can see over here, this is the vertebra. So we decide anterior and the posterior side. Now just in front of vertebra, you see a big round section. This is the descending aorta. Another round section which you see is the ascending aorta. Two big round sections. We have decided descending and the ascending. Now whatever structure is present anterior to the descending aorta, that is esophagus, and whatever another structure present near to the ascending aorta, that is the superior vena cava. So first you identify the anterior and the posterior side, then you identify descending and the ascending aorta. Near descending aorta, esophagus, near ascending aorta, superior vena cava. Okay, this is the section over here. Now coming to the head and neck over here, when we talk about the head and neck, with the help of Spinous process, we can identify C1, C2, C3, C4 till the C7. And when we specifically talk about this point, this is a junction of 3 and 4. And the junction of the 3 and 4 is, we know the junction of 3 and 4 is lying at the level of upper border of thyroid cartilage. So over here, this is regarding the lateral view of, or the lateral X-ray of the head and neck. Then apart from this, over here, the small section which is seen over here, this is a section of actually the hyoid bone. Okay, this is a section of the hyoid bone. Then coming to this section over here, now this is a sagittal section over here for the brain area, and this section we have already discussed, and we very well know this expanded portion is the pons. Above it, this is the midbrain. Below it, it is the medulla. Behind, this is the cerebellum, and this triangular area between pons and cerebellum, it is the fourth ventricle. Then the C-shaped structure over here is the corpus callosum. A projection over here anteriorly, this is the fornix. Then as we see this structure over here, this is the midbrain. This is a structure hanging from above. This is a pituitary gland, and in between the two, we can see a rounded structure. Now this is the mammillary body. So midbrain, mammillary body, pituitary gland. These are the structures which are present over here. Then apart from this, we know this is the corpus callosum. Below the corpus callosum, whatever area we are seeing over here, below the corpus callosum and this fornix, whatever area we are seeing, that is the area of the thalamus. Okay, that is the area for the thalamus. And if you ask me what is the area of hypothalamus, so the area which is present over here, this is the area of the hypothalamus, a small area over here. Below the thalamus is the hypothalamus. So these are the structures which you should be able to identify in this sagittal section of brain. Very important. Then this section we have already discussed. Now coming over here, transverse section of the medulla. If the transverse section is given in the midline, any prominence which you see, it is pyramid. Any prominence in the midline, pyramid. As you go lateral to it, this prominence is olive. And as you go more lateral, this prominence is inferior cerebellar peduncle. So pyramid, then you have olive, and then you are having inferior cerebellar peduncle. Now when you see the olive, in deep to the olive, one spiral nucleus is present, which is inferior olivary nucleus. And one more structure you should be knowing over here, that this nucleus present over here is a hypoglossal nucleus. The main structure is pyramid. The main structure over here, pyramid. Then the transverse section of abdomen over here, this is of abdomen. And when you see this transverse section over here, I will just, if you see this transverse section over here, again on the basis of this vertebral column, this is a vertebra which you can see over here, you decide that this is the posterior side and this is the anterior side. Now this big section which you can see over here, this is a section of the liver, and if this is a section of liver, we say this is the right side, and on the extreme this is the left side. So we have said this is the right side, this is the left side. Now this is a section of the liver. This round section over here, this is a section of the stomach. This is a stomach section, and when you go on extreme left side, you see a small triangular section which is a section of the spleen. So when you see this image, first of all you decide anterior and the posterior side, then you decide right side and the left side with the help of liver. On right side liver, then stomach, and on extreme left side you have spleen. And posterior to it, we say on the adjacent side of the vertebral column, whatever oval shaped structures you see is the kidney, and accordingly we say right and the left kidney. Now we have identified the organs over here. Now coming to the vertebra, when you talk about the vertebral column, when you see the vertebra over here, just anterior to the vertebra, a round section which is present. Now this is the aorta, and we very well know this is the descending aorta, and adjacent to it you see a oval shaped section. The section will be oval shaped or irregular shaped. That is a inferior vena cava. That is a section of inferior vena cava. So these are the structures which are important over here, and you should be able to identify all these structures in this transverse section of the abdomen. So we have discussed about all the images, all the one-liners, and as well as the clinical aspects. And the transfer sections we have discussed everywhere, because the transfer sections are commonly asked in the last 2 years exam. So there is a possibility that it can be asked in the next exam also. So now we are just ending this session over here. The revision we have completed, and I really hope that this revision is very, very helpful to you. And I will recommend to you to watch this revision at least 2 times. One you have watched now during this session. After this, by the night time or by tomorrow, you watch it again, right? And whenever you are revising anatomy later on, along with the revision of your workbook, play this revision video, which will help you to revise it quickly. So the revision video will be very helpful to you. And from my side, best of luck to all of you. I really hope that you do really well in your test, and as well as for your main test, which is on the 4th December. So best of luck from my side. Be positive always, and you can do it, and you will do it. So bye to all of you.